Outcomes Committee meeting. This is the Quality Health Outcomes Committee meeting. This is Lisa Bowie, Quality Improvement Director of OHA. I have black hair, beach background. I go by she, her, hers pronouns. Dr. Dawn Mottner, the OHA Medicaid Medical Director. She is out today, so you just have myself for OHA. And then for the CCOs, we have Dr. Doug Carr from Qual Health Alliance. Dr. Jeannie Salvage, our other chair, is out today. So you all rolling with Doug and I today.
Welcome.
For announcements, in your meeting packets, you, as always, have the actual Transformation Center Technical Assistance Guide, so please be sure to look through that. There's a couple different, as always, training opportunities through them. Of note, you've got the care coordination one, as always, and then some various different technical assistance updates. For today's agenda, I always do the reminders. Please remain muted when not speaking. When possible, raise the hand function on the Zoom features. That might be on the bottom bar or on the top. It's under the reactions button is your raise hand function. And then when recognized, please again try and use your name and your organization that you're speaking from. And and if at all possible, go on camera, because we'd love to see your lovely faces as well. It's in that virtual world that we're in. It'd be at least great to see some of y'all. Closed captioning is available. It's also again on the bottom part of the Zoom feature, so you can turn that on, and you can also have transcripts as well. Next slide. Thanks, Jennifer, as again for helping support this. Today's agenda, we've got a variety of different topics today. So we're going to have our pharmacy and therapeutics update, so our P&T update. We'll have a presentation from the Oregon Health Leadership Council on telehealth best practices for adult and pediatrics. We'll have a COVID update. Then we'll have a break. Then we'll have Dr. Ariel Smith. So Ariel again will present on our HOC update. We'll continue from May QHOC on a bupo and opioid prescribing. Then we just kind of have open-ended time. So if we'll be fluid if we're running late or if there's additional time on from the topics from the floor. In the afternoon, we're going to be talking about Exhibit I from the quality assurance team, and then we'll continue the conversation around the SUD performance improvement statewide PIP design topic as we're nearing your validation time period. So that's the whole agenda. Just a reminder to put your phone on mute as you're coming on. That'd be great. Next slide. And Mr. Roger Citron, you are up.
Good morning. Can you hear me okay?
We can, Roger.
Excellent. Roger Citron. I'm a pharmacist with the Drug Use Research and Management Program. I'm the director, and we had a P&T meeting on June 2nd. So going to share some of the recommendations from the P&T committee. Next slide, please. Here's a link to the OHA's website where you can find recordings and also the approved recommendations. Those were approved by the director on June 7th and posted. Next slide. At our P&T meetings, we have consent agenda standing topics. So new oncology agents that come to market are added to our oncology policy so that we make sure that these are prior authorized to be held to label or to meet NCCN guidelines. Again, the link at the bottom of the page will take you to our searchable web application where you can access all of our documents, but including the dedicated PA criteria. Next slide. Similarly, a standing item on our P&T agendas are our orphan drug policy, again, holding the drugs to be used appropriate place in therapy and their FDA approved label. And this is a link once again to our searchable website, and that'll take you to the orphan drug policy. Next slide. We brought tetracyclines back to the P&T committee. We actually reviewed this back in July of 2017, but we went ahead and posted our PA criteria. It hadn't been in the guide before. We allow up to 2 14-day supplies every 3 months without a PA. but just to make sure that maybe use that's more chronic that we want to stop and ensure that it's for a funded condition or approved, we'll stop those, and then they're subject to the PA criteria. Next slide. We looked at our sublingual buprenorphine policy evaluation. As you're probably aware, there's open access for all buprenorphine for MAT therapy for the first 30 days. Actually, for the fee-for-service, we don't require PA after that. The only thing we do is limit the buprenorphine to 24 milligrams. Again, looks like I didn't get this slide right. You probably don't want to conflate sublingual buprenorphine with Botox. So next slide. We also did a ADHD drug use evaluation, and we had a summary from the Drug Effectiveness Review Project. We're a member of DERP. Based upon that information, no changes were recommended to the PMP or PDL, PMPDP, which is the fee-for-service preferred drug list, based on that clinical information. We did get a recommendation from the committee to continue to monitor for combination therapy and see if we had changes in drug use over time. Consider some provider education. There was a lot of comorbidity in the data for mental health disorders for those members with ADHD. We then went into executive session to look at the confidential pricing, and the recommendation was to make Concerta preferred on the PDL. Next slide. We did a diuretics literature scan looking at the new agent Kerendia. We actually proposed dedicated PA criteria that's in the PA guide for phenynerone. It's non-preferred, so it stops for PA, but it also has clinical criteria that limits use to patients with CKD with type 2 diabetes and that are on background therapy with either an ACE inhibitor or an ARB. We went into executive session to look at confidential pricing, and no other changes were recommended for the PMPDP. Next slide. As you're probably all aware, this is a very dynamic class that we're bringing back to P&T again and again. So the targeted immune modulators get many different indications. So we looked at these for the asthma and the drugs for inflammatory skin conditions. There was a change to the guideline note 21 in the prioritized list of health services. So we wanted to memorialize that by including facial involvement in the severity assessment for PA criteria. Also, severe vitiligo is a funded condition, so we wanted that in the criteria. And we renamed that criteria topical agents for inflammatory skin conditions. We looked at the new drug ruxolitinib, and we maintained that as non-preferred on the PDL. We renamed the monoclonal antibodies for severe asthma to the TIMs for severe asthma and atopic dermatitis. Again, because of these expanding indications, that was a little more accurate. We applied it to Sublingual, Adbry, and Tezspire, and we also maintained those as non-preferred. Next slide. As I said, this was a big topic, so it's taken 2 slides. I don't know, the first time in my presentations I've used 2 slides for one topic. But we looked at severe atopic dermatitis, since that's an approved diagnosis now for Rinvoq, and so we put that in the criteria. We also looked at the threshold for the eosinophils down to 150. And we updated the definition of severe asthma exacerbation to include the oral corticosteroids. So then we went in to look at the confidential pricing. We hadn't really looked at the oral corticosteroids. So in this case, we recommended to make just the agents you can see on the screen: betamethasone propylene glycol cream, clobetasol propionate solution, and desoxymetasone cream, and hydrocortisone preferred, and all the other agents non-preferred. There's just a large number of them. Again, if you want to look at our searchable web application, you can type in any of those agents' names, and it'll show you all the agents that are preferred or non-preferred. Next slide. We looked at the Mycobacterium agent class review, and the recommendation at the end was to actually remove all PA requirements and all the PDL codings. Though the committee felt that they didn't want it to have preferred or non-preferred status, and they didn't want providers to have to navigate a PA when they were treating this. Don't have a lot of utilization, and so that was the recommendation the committee decided upon. Next slide. And that was it for what we went over in June. Our next P&T meeting is going to be held in August. So the meeting is scheduled for August 4th. We just posted last week the agenda and final documents. And again, those are available on our website if you want to go peruse those. If you haven't already done so, I encourage you to sign up for our listserv. You'll be notified when we post these documents, also our newsletters that we publish. And we also publish many of our documents in a draft form about 60 days before the meeting. And we entertain comments. So if you are inclined and have a particular area of interest, look at those documents. You can ask us questions, provide additional data. And it's a time when we're allowed to entertain that public comment with the authors and modify our documents. Once we get to the 30-day posting that just happened on July 5th, the next meeting, we don't change the agenda or the topics generally. Next slide. Once again, making a plug, the P&T committee has 2 vacancies. Physicians positions, they need to be an MD or a DO, actively in practice in Oregon. They're 3-year terms. And again, encourage you, if you know any providers that might be interested in this work and willing to volunteer, to get a hold of me to answer any questions. And with that, I'll answer any questions if there are some. All right, thank you very much.
Thank you, Roger. Next on our agenda is the Jill Lake from the Oregon Health Leadership Council. They have created 2 different guidelines on telehealth best practice recommendations, one for adults, but also one particularly focused on children. And it has a lot of nuances that are especially pertinent. I think that all of our CCOs have been encouraged to share these with their providers. And we certainly have done so at Unco Health. And the Oregon Medical Association has also done so throughout its, that I'm aware of. So Jill, if you'll introduce yourself and proceed.
You guys hear me okay?
Not really.
It's a little faint.
Let me see if I can turn it
Oh,
up.
that's better.
Oh, much better.
Much better.
Yeah.
Okay, cool. So I'm Jill Lake. I'm Director of Clinical Strategies with Oregon Health Leadership Council. Thanks so much for letting me come and talk to you guys today. I know that some of you here are involved in OHLC and our best practice committee and even our telehealth work group. So as I go through, I can't see the whole list of everyone's here, but if you have been involved in this and want to speak up and add anything, please do so. It would be super helpful. So next slide, please. Just a really quick overview. Like I said, I think a lot of you know about OHLC, but some of you might not. So just to kind of give an overview for those who don't, OHLC was formed in 2008. It is a nonprofit membership organization. It was formed at the request of actually the business community to help address rising healthcare costs. It's essentially a neutral convening table for the entire healthcare community in Oregon to collaborate on larger scale issues that people can't do on their own. And this org chart is just a kind of a high level overview of some of our current work. So on the left side is our board. Underneath we have our best practice committee, which I'll talk more about in a minute. Some work on value-based payment and a lot of work right now on Connect Oregon, which is the social needs referral platform that I know almost all CCOs are on at this point. And then we have a wholly owned subsidiary called HIT Commons. OHA is involved in the Commons, and its focus is really on aligned adoption and spread and use of statewide health technology tools like the collective platform and PDMP integration and HIE work. So that's kind of our whole world. And then next, page. So yeah, we'll talk about best practice committee. So I run our best practice committee. It's kind of the clinical arm of OHLC. Next slide. And this is what we have been working on at Best Practice Committee for the last, this is kind of since 2020, since the pandemic work, basically. We've been doing a lot of COVID response. We are working on creating some measures with the state on low value care. Our substance use disorder work group is working on creating an opioid use disorder in the emergency department toolkit. And then what we're going to talk about today is our telehealth work group. And I think Bhavesh is on the phone today. He was one of our co-chairs. Okay, good. And so I think probably a couple other people, but we, like Doug said, created some guidance that we'll go into a little bit more detail about today. So next slide. Oh, yeah, and next. Perfect. So our telehealth work group was created obviously in the response to the pandemic. So what we really started hearing was that a lot of organizations, the medical directors and the providers were starting to create their own telehealth policy, but they were really kind of doing it alone. They were creating lists of what is and what isn't appropriate for telehealth, but it was kind of all over the board, and they didn't have a lot of time to really dig into the literature. So Best Practice Committee asked us in September of 2020 to create a work group to identify, communicate, and support implementation of clinical best practice use of telehealth. So at that point, the technology platforms had really been built up and the payments had been expanded for telehealth, but the providers were really asking about a little bit more guidance on clinical appropriateness. So we gathered some subject matter experts from across the state and created 2 different primary care documents, one for adults and one for peds. So next slide. Our primary care recommendations, the adult ones were created and released in April of 2021. And then our pediatric ones were released just in January of this year. And the goal, like I said, really was to provide PCPs and pediatricians some guidance in determining whether a patient may be appropriate for a telehealth visit based on current literature and expert opinion. And as you guys, I'm sure know, there's a lot of literature and research in this space, but there's still a lot of gray area and a lot is being done. So we did rely quite heavily on our experts to come together to really come up with some of these recommendations. Our hope was that it was going to be used by providers as kind of a foundation in which to develop their own practice standards. So it wasn't meant to be regulatory or by any means. It was really just to give everybody a starting point to create their own policies, workflows, and things like that. Kind of an ancillary goal was to really demonstrate this nuanced nature of telehealth visits. So I said that, like I said, there's a lot of gray area. What we kind of came to was that there's not really a certain population or diagnosis or condition that's inherently appropriate or inappropriate for telehealth, but that there's a lot of different factors that go into it. And this was meant to really help providers understand those different factors, and also for payers to understand all those gray areas as well. And then also to highlight the importance of patient and provider choice. And then also to advocate for the continued support and payment for telehealth services beyond the pandemic and all of the emergency regulations. So next page. Included in the recommendations are kind of overall telehealth principles, overviews, and then the meat of the recommendations is spent talking about general and condition diagnosis specifics for chronic conditions, routine care, acute symptoms, and behavioral health. There's a special section in the PEDS recommendations for considerations in that population, and then resources. And so each of these documents is about 30 pages. So we can't go through all of them today. But I thought I would at least kind of share examples of what they kind of look like. So next slide. Let's see, one more. Perfect. So this is kind of an example of that overall introduction, when in-person visits are necessary. I think this came from the peds one, but they look similar in both peds and adults. So talking about the different clinical factors that providers need to think about, like distance to the nearest emergency facility, patient support system, all those kind of things that need to be considered. Certain conditions that might necessitate in-person visits, obviously needing a physical exam. If a patient has poorly controlled condition that might be at risk for acute complications. Anytime you need to assess safety or privacy concerns, things like that. We did put in the recommendations that the option to perform an in-person evaluation should always remain available, so that it should not be required that a patient needs to be seen by telehealth at any point. And then we added these telehealth principles that we hope people incorporate into their own telehealth policies, and they were adapted from OHA created these with, I think, 4 or 5 other states around telehealth policy. We adapted them a little bit to just incorporate actual telehealth delivery, things like access and equity and standard of care, patient choice, all the important things that providers need to think about. And then on the next slide, this is an example of the general recommendations that are included in each section. This one happens to come from routine care recommendations for the pediatric population. So it talks about what is recommended, what age of patients, if they need to be, new or established, things like that. When you would maybe think about an e-visit in established patients for things that are not time sensitive. Again, in-person visits. So this list is similar to the one on the other page, but really more specific to this routine care in peds. And then information about well child visits and sports physicals. We talked a lot about this in our work group because there's not really great guidance around it in the literature, and did ultimately recommend that an entire well child visit should be done in person. At the time, a lot of people were doing kind of both portions of it in person and portions virtual. So the recommendation was that all well child visits should be done in person, as well as sports physicals. And then next page. This is an example of the condition-specific recommendations that are found. So it goes into quite a bit of detail. This is an example of the acute conditions for pediatrics. So it talks about the reason a patient might come in for a visit, whether or not that reason is a candidate for telehealth, and some caveats under that. So for example, if a patient calls with a headache, yes, it's likely a telehealth candidate, but because there's a risk for a more urgent condition there, we recommend that a clinical triage is done. So it should likely go through like a nurse triage before scheduling with telehealth. It talks about the different platforms, which one is recommended. So again, for the headache, video is preferred. Telephone call is not recommended for the initial assessment, but might be recommended for follow-up. So things like that. In the chronic care sections, remote monitoring is actually added as a platform in some of the recommendations as well. And then talks about what telehealth services you should do via telehealth. Obviously, a lot of things like history, education, medication management, those are fairly straightforward. And then when to do an in-person visit. In the PEDS recommendations, we give age cutoffs for a lot of them, and also red flag warnings for a lot of the acute conditions that will help providers and organizations, hopefully with like their triage processes and things like that. And then next slide. This is some special considerations we included for the pediatric population. There's so much gray area, again, when it comes to peds, but things around parental and guardian involvement, around privacy, and making sure you're visualizing the patient, even if you're just having a conversation with the provider or with the patient or with the patient's guardian. Some legal considerations and consent consideration when it comes to kiddos. at-home examination devices. We also had a lot of conversation around this piece. These are things like at-home otoscopes that can send pictures across and things like that to providers. There's not a ton of data around it, and the group felt that because access to these types of devices is not necessarily equitable across the board, that at this point it's not recommended to endorse or require use of these types of devices, but they might be helpful in some cases where they're available. And then on the next slide, just some resources for providers and organizations that might be wanting to implement telehealth or expand their telehealth, figuring out what is covered, which seems to be changing all the time, and if they can provide care to an out-of-state patient. We still get a lot of questions around that as well, so just some resources for people. And then on the next slide, and really the reason that we came here today to you guys is that we had reached out recently to collect feedback on how people were using our recommendations, if they found them helpful. So we got feedback from our work group, from our best practice committee, and we did a formal survey to all of the recipients of the recommendations. And overall, what we found was a really positive response. They've been shared with providers, they've been incorporated or used to validate everyone, people's current telehealth policies, used as a reference for triaging. We know that some have even incorporated the protocols into their EHRs. So that was really great to hear, all the kind of robust ways that people are using the recommendations. We heard that the most helpful piece of them to providers was to identify when telehealth is not appropriate. So we know that the vast majority of the time it is, but the providers really did want some kind of backup when they felt like maybe it wasn't. There was no major barriers identified to using them, but the one thing that we did find was that a little over a quarter of the survey respondents were unaware that they even existed. And so we wanted to come to you guys and to others to kind of give another push to help us kind of get these into the hands of providers. If you go to the next slide, just ask, yeah. Our distribution lists generally go to medical leadership, and we rely on them to get them into the hands of individual providers. And we have a hard time with that sometimes. So our ask of you guys is to please share them if you have not. I know a lot of you have, and thank you so much for doing that. They are linked here. They're really easy also to find on our website. And then just an FYI, we are currently in development for some new recommendations around outpatient behavioral health. So those will be the next ones coming out. So if you have any guidance or suggestions on those, please reach out, let me know, or let Bhavesh know. And then when they're done, if you could share those again with your network, that would be super helpful. And then next slide is questions. That's all I have. So if you guys have anything, please let me know.
Yes, from Doug Luther.
Yeah, we've got questions.
Thanks, Doug. It's Doug Luther from Care again. Hi, Jill. I got a question. Is there any intention to look at specialty telehealth type visits? You talked about behavioral health being on the docket next, but what about specialists? Because you're probably aware, right? There's been some issues with what I call mercenary providers out there nationwide, sort of providing telehealth services that are problematic.
Yeah, so when we originally started, the list that we had was primary care, behavioral health, and OBGYN, like women's health, was kind of on the docket. So we've kind of followed that so far, but that being said, this is a space that changes so much that I think that after we do each one, we are going to go back and ask the group and ask best practice, is this still the biggest priority? So that's what we have planned so far, but those are things that can just change based on the needs of the community. So more to come.
Kevin?
Good morning, Jill. Great
Hi,
presentation.
Kevin. Thank you.
I should know the answer to this, but I can't recall from our best practice committee meetings. But related to the upcoming behavioral health telemedicine work group, does that also include substance use disorder, SUD?
Yes, it will include it.
Okay, great. That's what I thought, but I just wanted to make sure we called that out.
Yeah, it's its own whole section in there. So, yeah.
Great. Wonderful.
So Jill and Kevin, do you have an idea of the timeline for release of that?
Not at this point. We're probably a quarter of the way through them, and they take a while. So I'm hoping by the end of the year they'll be out. They definitely, but I would say I'm very confident that by the end of the year they'll be out. Yeah.
Well, that segues in with some of the development of new OARs around that for the Medicaid population. And so there's a lot of, it's a hot topic right now, let's just say. And I would encourage the CCO medical directors, majority of whom are not behavioral health based specialties, to get your behavioral health managers, directors, and clinicians involved with providing some input to your process, Jill. So I'd encourage that.
Yeah, and we do have quite a few. Our CCO participation has been great, but if anyone else is interested, we welcome for sure.
Excellent. Are there any other questions for Jill? Well, thank you so much. I appreciate it. Oh, here we go. Kevin's a follow-up.
Sorry, I was late getting
No,
my
it's
hand
okay.
raised. My question is more for the CCO medical directors and other attendees, but in what way, now having heard this information, is this a surprise to some of you? Are you already aware of this important work that's going on? And then the next steps of how are you planning to share this with your contracted provider network?
Well, although we've done that before in both our provider newsletter and a direct email to all of our contracted providers, but I think that we'll double down on that this month as a reminder, because if you think about it, the average number of hospitalizations nationwide have gone back up to March levels, and we expect the Biden administration to extend the public health emergency declaration to October 15th again, very shortly. So it's still very pertinent, but it's also pertinent, I think, for the post health emergency world, because we're not going to go back to the way that we practiced medicine before. This is here to stay, and it's just a matter of now trying to really define when, what the appropriate use of that is. Marie, you have a question?
Yes, my name is Marie and I work for Family Dental Care, which is a DCO under Oregon Health Plan. And we are in the process of creating our telehealth for dental. And I'm just wondering, I was really excited about the topic today, but I understand why most of this is on medical, but is there any information that, could be coming out soon regarding the dental side of things for telehealth?
That's an excellent question, and I do know that our contracted DCO uses quite a bit of teledentistry in order to comply in part, not only outreach, but also it's very pertinent to complying with some of the dental metrics that we're subjected to. So that's an excellent question. Jill, do you have any idea of incorporating that?
No, that was definitely a topic of conversation that came up, was dental, and it's kind of on the list. We can only get through one at a time, but it is on our short list. But I'm not aware of anything else.
Well, it may be, since it's already partly in place and actually occurring, to a fairly wide degree among the DCOs, you may want to, that may be, the fourth one on your list. You may want to consider that. Marie, did you have a follow-up question? And then Lisa?
Oh, well, I just have a follow-up comment to just kind of, put my 2 cents in for making that higher on your priority list for a couple reasons. One is it is pretty widely done out there, and we're trying to do the best we can to get it up and running in a way that's works for our members, and is not as easy to do and not confusing to them. But also because I don't know if anyone is aware of it, but on the medical side of things, but on the dental side, we are in an extreme shortage of providers, and we lost almost a third of our hygienists, according to the Oregon Board of Dentistry, in the last year and a half. And so with our extreme shortage of providers, that we're really hoping that this telehealth will help us to be able to see our members and get members at least some type of care as best as possible and as short as possible because of our access issues and whatnot. So I would really recommend it if possible.
No, that's super helpful. I'll definitely bring this all back to the group.
Thank you.
Lisa, did you have something before Kevin?
Yeah, I'm just gonna, before I forget, and for more records, and Jill, we can always talk offline. You and I can touch base on behavioral health and who you're connecting with within the agency to make sure you have the right connection points within OHA for that, for the STD and or behavioral health best practices. And then secondly, for the ones that are already established, if we haven't already put it in our Provider Matters newsletter, which is the distribution from the state to a whole host of provider people, then we can connect about that as well. So if we haven't done that, we should probably connect about that.
Yeah, I don't think it's been in there. That would be great.
Okay, so yeah, let's talk about that, Jill, and we can talk with Dawn when she gets back from her time off about, whether and how. I know how to do it, but we'd obviously want to talk with Dawn, the medical director, about that as well. But we can talk about a couple different distributions to providers that the agency has.
Perfect.
And lastly, Kevin?
Thank you, Marie, for the comments about dental. And I do have a question for you and the other dental or DCOs that might be represented on this call. And the Best Practice Committee is made up of volunteer physicians from CCOs, delivery systems, hospitals, health systems, and other associations. And my question would be, do you feel that the DCOs in Oregon could get together and actually be a work group that could put together some of the important dental work as it relates to telemedicine, and then have that report up to the Best Practices Committee, where we could then disseminate that across the state?
This is Dana with the Limit Dental. Can you hear me?
Yeah.
Yes.
So this would be a group that OHA puts together?
Hey, I'm going to step in here. This is Lisa. Dana, what I think Kevin's asking is, would DCO representatives want to volunteer? Because again, the OHLC is a volunteer-ish group. Would they want to volunteer and form a DCO volunteer group to help lead a dental telehealth best practice subcommittee group? And I'm getting a lot of head nodding from Kevin, and that's what I'm thinking where Kevin's going.
That's exactly the question. Thank you, Lisa, for
You're
paraphrasing
welcome. I'm
better.
just doing a full lot of interpretation. So
And I think the OMA would, would encourage that, or it could provide some framework for it. But obviously, the Oregon Dental Association could weigh in on that. But I assume, Kevin, that you'd be more than happy to share your framework that you have for these other committees.
Yeah, and I'm not sure what you meant by OMA, seeing it's only represented by physicians and physician assistants in Oregon.
yeah, I should suspect it'd be a subgroup within the OHLC of the
Yes.
best practices group.
Yeah.
But it'd be
Thank you.
a dental plans participants of the best practices group under the OHLC.
HLC. Yeah.
Okay, all right.
So if that makes sense to any of the dental plans that are on this call, and what I would recommend for any dental plans that are on this call, Marie, Dana, and whomever, I'm happy to come to your DCO plan meeting and be the conduit from this discussion to the dental plans meeting, because not all the dental plans come to this meeting or vice versa. And we can say, hey, we had this conversation at QHOC, and here's a suggestion to all the dental plans. And I can do the introductions to Jill, or Jill and I can both come over there. And if we want to kind of carry forward this best practice conversation, Jill can take it through the actual OHLC actual group itself. But this is what Kevin, who also, does Kevin sit officially on the best practices?
Kevin's our chair.
Oh, well, so Kevin chairs it apparently. So there's Kevin's suggestion. Then Dana and or Marie or whomever, I can help get that through your DCO plan meeting. And then if there's enough interest, then we can help facilitate making that with Jill and Kevin.
Bhavesh?
Hey, thanks, Lisa.
Yep, Dana, you and I can follow offline, and Marie, whoever, you can all email me.
Yeah, thanks, Lisa. I just wanted to commend the work that's going on through OHLC. Jill has spearheaded some, a lot of activity and work and research, and she does do a lot of research to look for evidence. But as we bring these different specialty groups together, whether like, for example, for behavioral health, we had to find psychiatrists, behavioral health clinicians, SUD providers, to come to the committee, because we can't, as other types of doc, primary care providers and so on, know all the ins and outs for, these different areas. So the same will go for dental. And as we develop, these kind of guidelines, we need the expertise at the table. We need people to participate. We need people to be able to give us the guidance that we can then put to action and, and help us craft the set of ideas. And none of what we're doing is related to payment, by the way, or payment models. It's all to do with best practice, evidence-based, patient safety, those kind of things. And it's not to do with whether an insurance company should pay for things or not. And that it would include, hopefully how the DCOs should understand how this process is. It's about what we should do. Does it work? Does it work well? Does it cover the needs for our community properly, rather than anything else? So I would definitely invite participation. We need the participation to be able to make effective sets of rules, and the participation from those folks who are in the know, who work that area. Thanks.
Thank you, Bhavesh. I think we have to move on. The last thought I had was, this is the intersection of primary care and dental care is occurring in all of our CCOs as our DCOs are integrating dental care into the primary care setting, and it includes teledentistry. So that's why it's even doubly more important, because it's actually occurring within the confines of our primary care practices. So I think we need to move on, Lisa. And thank you, Jill. I appreciate it. And good luck on Godspeed on your next project, behavioral health.
Thank you.
All right, moving on to our next Jill. Jill Johnson, who's our clinical vaccine lead for the COVID response and recovery unit. And if you'll take it away, Jill, thanks.
Great, good morning. So clinical vaccine lead, COVID response and recovery unit at Oregon Health Authority. I'll be providing an update on pediatric vaccine rollout and boosters. Next slide. So the vaccine rollout for children under 5 is going well. Both Moderna and Pfizer vaccines for young children are available across the state. The most recent data upload was on Wednesday of last week. And so as of July 5th, more than 85,000 doses had been delivered to providers and hubs in Oregon. Beginning this week, actually, the vaccine for young children falls into a similar routine for ordering and shipments as other vaccines. So providers will receive vaccine as they draw down doses in the alert registry. The graphics on the bottom of the page show the vaccination schedule that's recommended by the ACIP, or the Advisory Committee on Immunization Practices. On the left is the recommended schedule for most children. Pfizer is a 3-dose series and Moderna is a 2-dose series. On the right is the schedule for children who are immunocompromised. This series for Pfizer is the same, but an additional primary dose is recommended for Moderna. Next slide. Looking at anticipated demand, Oregon has about 222,000 children between 6 months through 4 years of age. Looking at history and the 5 to 11-year-old data, we expect about 27% of children under 5 will be vaccinated in the first 10 weeks, which is about 62,000 children. Based on vaccine already distributed throughout the state, we have plenty of supply during these first 10 weeks to meet the demand. And as of last Tuesday, the 5th, 8,634 children in this group had received their first dose of COVID-19 vaccine. This is about 3.9% of the total population in this age group. And the rate of uptake is similar to what was seen in the vaccine rollout for the 5 to 11 years old. So it's kind of in line with what we were expecting. And then just a note that no booster doses have been recommended for this age group at this time. Next slide. We've really made a strong effort to prioritize equity across the state. The initial rollout for the 6 month through 4 and 5 consisted of a tiered approach. And so the sites that were serving or are serving minority and diverse populations had first priority to receive the vaccines. So the first wave allocations included Indian and tribal providers, local public health authorities, FQHCs, and the redistribution hubs that can store large quantities of vaccine and then make the smaller and urgent transfers to providers in their regions. And then the OHA field operations teams have been very busy. They continue to do mobile clinics in communities across the state. They actually began vaccinating the under 5 age group during that very first week of rollout. They began on June 23rd, vaccinating the little children. There's been a focus on getting doses to sites with the diverse populations to rural areas and all corners of the state. At this point, vaccines have been distributed to all provider clinics that requested doses. Not all providers are carrying both Pfizer and Moderna, so we're advising parents to call ahead to their child's pediatrician or local public health to inquire about vaccine availability and to find out when they can bring their child in for a vaccine. Next slide. This slide is a review of the various locations and access points for COVID vaccines. Just a reminder that COVID vaccines are free to everyone. No ID or proof of citizenship is required to receive a COVID vaccine. We know from surveys that most parents will likely get vaccines for their children at their pediatric provider clinic, where they have a relationship established already. But other options include local public health clinics. Pharmacies can vaccinate for 3 years old and up for COVID vaccine. and then of course the Oregon Health Authority field operations. They continue to operate high volume vaccination sites, the field operations, in partnership with Lane, Multnomah, and Washington counties. All of the high volume sites offer vaccines for the under 5 population. And they also conduct mobile clinics in communities across the state. And actually this week they have 53 clinics scheduled across 16 counties. They're also doing some more pointed outreach to reach vulnerable populations and arrange mobile clinics. And those include adult foster homes and in-home care, farms, long-term care, and licensed child care agencies. And then a great place to find a vaccine is the Get Vaccinated Oregon site online. Super easy to use. You just put in a zip code or an address, and you can find the locations nearby that offer vaccination. It also includes the hours, walk-in or by appointment, and the vaccines available. Next page. Just wanted to mention that we've been hosting a pediatric vaccine learning series to go alongside the vaccine rollout for the youngest children. There were 4 sessions altogether that covered various aspects of clinical practice and COVID vaccines for children. The last one is coming up on July 21st, and the topic is strategies for vaccine catch-up, and we're going to talk about both COVID and non-COVID pediatric vaccines. Next slide. I wanted to mention that Moderna for the 6 to 17-year-olds was authorized. That occurred on June 27th, and providers can order Moderna for the 6 to 11 age group in Alert. This is a 5-dose vial that's also used for adult booster doses. The vaccine for 12 through 17 is already in use. It's the red cap vial. And the recommended primary series is 2 doses for most children, and then a 3-dose primary series for children with immunocompromising conditions. Next slide. Slide provides current booster recommendations. The booster doses are now recommended for everyone 5 and older, and the booster should follow the primary series of Moderna or Pfizer after 5 months or 2 months after a dose of J&J. And then second boosters are recommended for the 50 years and older population, the 12 and older who are immunocompromised, and then anyone that received a primary and a booster dose of J&J should receive a second booster dose, and it should be an mRNA vaccine. Next slide. A bit of data here. This graph shows the 7-day running average for total doses administered in the state. In the week leading up to July 5th, about 3,500 doses were administered for all age groups combined. Around 1,100 of those 3,500 were first doses, about 700 boosters, and then 1,400 were second boosters. Next slide. And then this slide shows vaccination coverage for people of all ages in Oregon. We're up to 75.6 of Oregonians that have received 1 dose or more of COVID-19 vaccine. About 69% have completed a primary series, and 40% have received a booster of any of the COVID-19 vaccines in addition to completing a primary series. Next slide. This slide shows percentage of the population of various age groups who've received primary series and boosters. We now have data for the under 5-year age group on our dashboards, and anyone can access the data through the OHA website. So if you're looking for something specific, go look around there. There's lots of data posted. Next slide. And then this one shows vaccine and booster rates for race and ethnicity. We're continuing to work to close that gap for the Hispanic Latina population through community-focused work and mobile clinics. In addition to the tiered vaccine rollout approach and the redistribution hubs making vaccine readily available across the state, we continue to work with providers serving diverse populations to ensure vaccine is on hand. Another way we're supporting clinics is through workforce augmentation, where supplemental staffing is placed where needed in support of COVID vaccination and therapeutics. Priority organizations to receive workforce augmentation are FQHCs, rural health centers, and high volume vaccination sites that serve diverse populations and are not part of the hospital system. Thank you for your time. That's all I have, and I'm happy to take questions.
Any questions for Jill? That was a really comprehensive review. The details are, you know, the devil is in those details behind that. Red top, blue top, purple top. This is a very confusing landscape for providers.
Yeah. It's getting very complicated for sure. Lots of products, lots of indications.
And yet to be announced this fall, the recommendations for, particularly for fall-based COVID boosters, is there?
Yes, there has been an authorization to include Omicron in a booster dose, but we don't know yet when that will be coming. So specifics to come.
Okay. Bhavesh.
Yes, thanks for the review. A couple of things that have come up at primary care clinics when we've talked about some of this. One is around, you know, the ongoing groups that won't take the vaccine and how we approach vaccine hesitancy and education for providers with that. The only real education I've found is through Boost Oregon, and there's a cost to that. So I'm wondering if there's some videos that we can have developed that we could share easily with our provider groups, that we could perhaps have OHA help us with getting some official videos made around vaccine hesitance, if that's possible. And then the second question that always comes up is reducing the number of vaccines that people have to take. And I think one of the biggest support for a vaccine in the fall could be if it could be combined with the flu shot. And if we could get a booster that has the Omicron variant within it, and we can give it with the flu shot, that'll make life a lot easier for everybody. Thanks.
Yes, to your first point, the OIP, the Oregon Immunization Program, is going to be doing a big push this fall. They're working on regional meetings with clinics and local public health to really try to jumpstart the catching kids up for the entire ACIP pediatric recommended schedule. And I know that part of that is resources for providers and talking to parents about vaccines. So, but I'm glad you brought that up, and I'll definitely relay that back to the team. And then as far as the boosters, I do know that is that has been discussed, including the COVID booster with a flu vaccine booster. But Again, we just don't have very much information yet. It's kind of in the early stages, but it will be coming soon.
And your group, Jill, has created a number of videos on YouTube, and they're described in the Transformation Center
Yes.
newsletters that are sent out each week, and the innovator agents often repeat that. You're on mute.
I'm mute. There is quite a bit of information on the COVID website that providers might find useful even at this point. The CDC has a great quick, kind of a quick guide on conversations providers can have with parents. It's just a one-page, well, maybe a couple of pages with common questions about the COVID vaccine and how to approach those conversations. So I can definitely forward that to Lisa to share with the group.
Thank you. Well, let's take a quick break. And Lisa, should we come back at 10:10 or 10:15? Or I'm sorry, 11:10 or 11:15?
We've got the time. Why don't we go ahead and go 11:15?
Okay.
And then I'll just let John know that we're running a little bit.
All right.
So Ariel's usually with us for the long haul, so we should be okay.
Thanks. We'll see you at 11:15.
Jennifer, were we able to swap out the newest slide?
Yes, we were.
You're amazing. Thank you.
Yep.
Yay, thank you.
And
Sorry for
I'm
the
sorry
very
about-
last minuteness,
Sorry
as
about
usual.
jinxing you, Ariel. That was, not my intention.
Well, thank you. We're back in session, and next on our agenda is an update from the HERC, and Ariel Smits, take it away.
Hi, everyone. Just to remind you all, my name is Ariel Smits. I'm the Medical Director for the Health Evidence Review Commission. And these are your slides. This should all be in your slide deck, except for the next slide, which that's what we were just talking about. We had a last minute substitution. So next slide. What was in your packet was a blank slide. It was the first time in 2 years there were no COVID codes. But then, of course, at the end of last week, there were COVID codes. So, but you shouldn't be surprised having just heard about the pediatric codes. So they issued new codes for, it's the existing Moderna vaccine, but it's now the administration, the three codes for older kiddos, and then a new code for the Moderna little kiddos, as well as their 3 administration codes. So these are all, just to remind you, effective immediately. You probably are already getting, hopefully, claims. So these are all going to go on line 3 and will be hopefully open now for anyone who's doing pediatric vaccinations. So if any of you want this slide, I'm happy to send it around, or have Jennifer or Lisa send it around after the meeting, since you don't have it in your packet. Next slide. So our next meeting is on August 11th, and as usual, you are all invited to come and observe or take part, or whatever you'd like to do. The big thing on our agenda are the 2023 ICD-10 codes. I don't know if you've seen them yet, but there are like 2,000. I mean, it's some crazy, insane number of new codes, like 2,000, like 1,800, something like that. So there is a lot there. None of them seem terribly controversial. We're kind of working through a few of the behavioral health ones that are going to go to our BHAP group that we're convening this month. There's also a few that may end up being used for social determinants of health and other things, but keep your eye open for when we send the packet out. It'll have all those new codes. Those will not be effective, except for there's some random COVID codes you've already seen, but the 99% of them won't be effective until January 1. So that should give you some time. I'm sorry, October 1. They're all effective October 1. We are looking at our acupuncture guideline clarification. Currently, it says that you need to be in an SUD treatment program for acupuncture. The intent is really that you just don't use acupuncture as a sole treatment for SUD. It's more you need to have other pieces in place. It doesn't have to be a formal program. So we're going to clarify that. Burst fractures of the spine. We discovered that these are all over the place and many are on uncovered lines. These are all unstable fractures and should be treated. We are looking at our tympanostomy guideline based on pediatric ENT input. We're going to make a few rather minor edits to it based on the 2022, the American, whatever their initials are, the American Academy of Otolaryngology head and neck surgery. They came up with new guidelines for tympanostomy tubes. Autoimmune encephalitis, this kind of comes on the tail end of our PANS review. Autoimmune encephalitis is a different entity. It's a very serious condition that usually occurs when there's something like a brain tumor and you have an autoimmune reaction to it. These people are incredibly sick and they're in the ICU. It's kind of unclear whether we cover treatment, although you probably already are because these people are pretty much all hospitalized. But we are going to clarify that and clarify that the codes used for this are not to be used for PANS. We've been asked to look at the human growth hormone treatment for adults or people with Prader-Willi syndrome who have closed growth plates. The evidence there is not really good, so we're going to clarify that, the suggestion is to clarify that we don't cover after bone closure. Then congenital foot deformity review. I've been working with several podiatrists looking at some foot deformity issues. I don't know if this actually will be ready for August. It's already been bumped back once, but trying to get a lot of people's attention in the summer can be difficult to kind of help me review these. We've been asked to talk about when do we cover sleep studies for Cpap titration. So we're working on a guideline for that. We're looking at microsatellite instability testing. This is a test on tumor tissue that's actually become standard of care for things like colon cancer. We currently have it as non-covered, but we are suggesting that it be covered for diagnostic testing. Next slide, please. Our scoliosis guideline, we currently limit it to people 18 and under. We had a provider request that we look at that because there are cases where some people need surgery a few years older than 18. So we are considering removing the age limit and just calling it adolescent or congenital, or so basically something to indicate that it's not like the adult onset based on like aging, but it's more the adolescent based on growth, etc. We're looking at autologous chondrocyte implantation, which is a knee procedure. Looking at indications for surgery for tethered cord, which is when the spinal cord is tethered into the spine. We are looking at having an official policy for use of quality adjusted life years, or QALYs. This comes from disability advocates. We currently don't specifically use QALYs, but we do review many evidence-based sources that might include discussion or mention of QALYs. And there might be some prior prioritization based on QALYs. So we just want to clarify that we don't specifically use these, but we may include them in materials because of the nature of the articles. Bronchial thermoplasty came up for re-review. It hadn't been reviewed in many years. There's still no evidence that it's really effective, so we're just going to update our date of last review. Then we're looking at a couple things for the 2024 biennial review. The first is coverage for TMJ, or temporomandibular joint syndrome. My review of this shows that there really still is not any effective treatments, and the recommendation is going to be continuing to not cover or have those lines prioritized below the funding line. We also are looking at disorders of sleep. There's good evidence about cognitive behavioral therapy for insomnia. I'm going to first bring this to our behavioral health group to kind of walk through what kind of coverage this would look like. The evidence for medications for insomnia is that they're effective for the short term, like 2 weeks, but they're not effective and possibly harmful in the long term. So we would probably add some kind of a guideline saying, like we do for PPIs for GERD, that you could cover sleep medication for a couple of weeks and then not cover after that. But again, this is sort of in review. I actually, since our behavioral health group is not meeting till the end of July, this may not actually get discussed till October, but you'll hopefully hear more about it at a future QHOC. And then we're continuing our below the line review. We've been looking at just trying as staff to look at anything that might be inappropriately below the line and moving things above. We also have, since these slides, multiple other things that you all have brought to my attention over the past week or so that may or may not come to August. Otherwise, they'll come for the fall, and definitely keep sending me questions and messages and such, because definitely we use that as basis for looking at topics. Next slide. So as I mentioned, our Behavioral Health Advisory Committee is meeting at the end of July. There are 80 new ICD-10 codes that are behavioral health related. Like I said, it's an insanely large number of codes this year. One of the things that's going to come out of this is probably looking at our dementia line. Some of the dementia diagnoses are on the dementia line and on our dysfunction lines, and some are only on the dementia line. So kind of looking at the dementia line and seeing if we just want to make it a little bit more inclusive of some of the therapies they might need and take them off the dysfunction lines or something. There's a couple new codes that are related to substance abuse disorder, most of which are probably just going to go in the substance abuse line, one of which is alcohol use unspecified, which could just be what my alcohol use is. So we're probably going to make that informational. I'm assuming that is just people using alcohol, but I'll ask what the behavioral health group feels about it. And then, as I mentioned, there's some social emotional health related codes that we're going to discuss. We're also discussing conduct and impulse disorders. These are currently on lines below the funding line, but we have heard from pediatric advocates that they should be moved above the line. And we've been working with our partners at the OYA, the Oregon Youth Authority, and so kids with this who are in under the OYA's care receive care for this through a different funding mechanism, but when they're released from jail or whatever they were in, there's some discontinuity of care, and we've heard from some other parts of the agency that this would be helpful to cover. So that's the proposal, and we're going to see what BHAP thinks about that. I also, as part of the below the line review, discovered that we have some drug-induced movement disorder codes that are below the line. These are things like dyskinesias from atypical antipsychotics. We'll add those to covered lines. And then childhood disorder of social functioning. These are some somewhat vague codes that the schools, the education groups have asked us to look at for possible coverage. And I'm going to bring that to BHAP to see if this is something that should be funded through the schools or through the medical plans. So stick tight and you're welcome again to, as with all of our meetings, to attend this meeting. It's virtual, so you're welcome to sit in. Next slide. EBGS met in June. We looked at our high frequency chest wall oscillation again. It's kind of gone back and forth for a while. This is wording you've seen before for cystic fibrosis. They didn't change anything about adding coverage for chest vest or CF. Next slide. Next slide, please. The big change is that they are thinking about, they re-added in coverage for non-CF bronchiectasis with guidelines. It has to be confirmed by CT. You have to have a daily productive cough and frequent exacerbations requiring antibiotics. And you have tried some other therapies or they're not available or indicated. Next slide. And then this is the wording that you have seen before. We haven't changed it. So neuromuscular disease coverage for those people who have sort of chronic evidence of chronic lung infection, and then recommendation against coverage for COPD. Next slide. We also talked about our scoping document for continuous blood glucose monitoring for diabetes. Just to remind you all, we cover this for type 1, but not type 2 diabetes or gestational diabetes. We discussed the scope document, and the recommendation was that this has been recently discussed, and we should bring it up again in a year or two to let the literature kind of to see what new studies and new things are out in the literature. That decision of tabling it will obviously be pending a HERC discussion and decision. We also discussed, or we are planning on discussing bariatric procedures. That's our plan for our September meeting. So this is looking at both types of procedures as well as indications, such as should we expand to overweight, or should we lower the BMI, or should we add any comorbid conditions? Although I think that's pretty vague wording already. And we're also going to look at coverage for adolescents and coverage for outpatient centers for certain procedures. So if you have any specific questions or interest in bariatric procedures, keep an eye out for that September discussion. Next slide, please. EBGS is always looking for topics. So if you have any suggestions or ideas or things that you think would be appropriate for them, please forward them to us. Next slide. I wanted to point out to you all, this is really important. Our emails are changing. So OHA, actually it might be beyond OHA, are converting all of our emails. The first group that got converted was group emails. So our herc.info is now at oha.oregon.gov. That's completely different. It used to be just like the ones after our names, the DHS OHA state.or.us. That email will continue to come to us as they sort of roll this change in, but we're not sure how long that grace period is. So please make a change now to any of your contact lists or whatever and use the updated herc.info. Our email addresses are continuing to be the same. However, we anticipate they will also convert to the new form at some date that we are not have not been told yet. So it's really important if you want something to come. We have noticed that there has been some things bouncing from the herc.info box, even with this grace period that we have been told we have. So use the new email address. With that, I'm happy to take any questions or any input from you all, or topics that you think that we need to start looking at, or any other input.
Questions for Ariel? Ariel, as part of the contract changes for 2023, the OHA mentioned EPSDT, that they will be coming out with further guidelines for how CCOs are to have an expanded review process for those under 21 to make sure that it's for medical necessity as well as medical appropriateness. How does the HERC, how are they involved with this process as they review things?
So the HERC's involved in a couple pieces. We added to one of our statements of intent. I think it was a statement of intent.
Right.
Statement of intent for that things should be covered if they are needed for a child's growth or development. So that guideline change is in effect. We also have been scouring the below the line region to make sure that we're moving things above the line that are appropriate, so that you don't even have to do that review. Hopefully that it's been updated already for you all. The actual process of what OHA is going to ask you to do, or what guidelines, I'm not privy to those discussions. I don't know if Lisa has any comments. Dawn Mottner probably would be also another good person to check in with about that.
Okay.
Goodbye, Dawn.
Lisa, did you Did you just punt it to Dawn? Okay.
More at 11. Well, thank you very much, Ariel. I appreciate it, and we'll note the address changes. I certainly send a stream of them to you directly at all times. So,
Yeah, that's great. No, thank you all. We are happy to get your emails. If it's something we can answer quickly, that's always great for us. If it's something we need to take a good deep look at, that's also good for the OHP population.
good.
Yeah, I think the emails will continue to get forward for a transition period. At some point, they will. I know I can't send out from the old email anymore. Like that, I know is like that's cut off. So we can't send from the old email, which is definitely changed. So,
Yeah.
but
Yeah, and Lisa, I've had a couple of like people telling me I got something sent back. So I'm not sure how or why that's happening for certain things. But just to make sure, and also if you send us something to HERC.info and you don't hear anything for a few days, just double check that you sent it to that new address.
yeah,
And then again, all of our email addresses will be changing because it's the state and they feel like they
let me be
to
clear.
stir things up, I guess.
It's not the individual. So like Lisa Bowie email is the same, but
Right, but yours is going to change at some point.
will it? I
Yep.
thought it was just
The domain is different.
Yeah,
Yes.
they're starting with the group emails and then they're going to go to individuals. Oh, I just ruined Lisa's day.
I know, we lost her.
great.
Well,
Just make it a Monday.
all right.
Yes, it'll be like Monday morning and you'll come in and all your emails will have stopped working.
You know what? That's the best way. You know what? It's the best way to clean out my email box. Just change my email address. I'm fine with it now. There's the positive, silver lining.
Okay. So the last agenda item scheduled for this morning is John McIlvaine. Is he on?
I don't know. I was just messaging him to let him know we're running a little bit early, but let me just take a peek. Hang on. He says, oh, he's finishing off a meeting on harm reduction, but let me forward him the email, the appointment. So that's step one. Let's get him the actual appointment link. And then I will tee us up for the actual conversation since we've already pre-met, and I'll kind of do a reminder anyways while he's finishing up his other meeting, and then he'll join us over. And actually Ariel, and we have some others that are part of this conversation in addition to John. Okay, so I've invited John. He'll finish up his meeting and then I'll go ahead and tee us all up. Okay, so as a reminder, let me just let him know I sent it. Invite. As a reminder, y'all briefly touched on this topic in May. That was a meeting that I actually did miss. So I touched with the team, a variety of folks, the Health Evidence Review Commission, the pharmacy team, and then the SUD team. So John McIlvaine is our state addictions officer. He'll be joining shortly. The pharmacy team, when I say pharmacy team, that's a whole broad set of folks. That's Roger Citron, D. Weston, Andrew Gibbler. Those are kind of a whole host of pharmacy folks. They represent the fee-for-service pharmacy, as well as the P&T committee that kind of, again, works within the CCO pharmacy world, as well as fee-for-service pharmacy. And then obviously we just heard from Ariel, and then Jason Gubrich as well within the HERC world. So we have all been conversing with our SUD team, again, John McIlvaine, on this conversation around buprenorphine prescribing, potentially in the world of the intersectionality between buprenorphine prescribing and chronic pain patients. So y'all had this conversation, I believe, briefly in May. And so didn't have a lot of time to talk about it. So we wanted to come bring it back in, well, in July, but we honestly didn't have time. So we ran out of time. And so then I said, John, we'll just bring it back into, or in June, we'll bring it back in July where we have a little bit more time and not a learning collaborative butting up against the schedule. So John will hopefully join over here shortly. And the conversation really is really looking to you all in the CCO world, and you're hearing it in your community with your provider networks and what you see on a day-to-day out there in the world of practice. Are you seeing buprenorphine being prescribed for chronic pain patients? That's just an actual question. So that's us, the agency, asking you, the network, if that's something you're seeing. And then we're just trying to find out if that's a practice you're seeing. And then we're trying to figure out from the policy side and the practice side, what, if any, changes need to be discussed and or made. So we're not making any kind of decisions now, nor are we making any kind of declarations of whether a practice should or shouldn't be happening in there. We're just trying to find out what's happening, if that makes sense. Any questions or any carry forward from May that people want to just put out there before I just, any?
This is Dee. I just want to clarify one thing. When we're talking about buprenorphine for pain, we really mean the buprenorphine containing products that are labeled for medication-assisted treatment. I understand that there are some buprenorphine products that are actually for pain, but we're talking about the ones that aren't actually on label for that. So.
Thank you, Dee. So what are people seeing in their communities in regards to this?
I'm going to jump in again because, oh, good. There's somebody with a hand up. I know from my experience in talking with folks from other states, they sometimes find out about this when they're reviewing prior authorization requests. So I know you won't have prior authorization in the first 30 days, but after that, you probably are seeing prior authorization depending on the CCO, and that might be an opportunity when you would get some insight into that. But looks like Kent has his hand up.
Yes, Ken. You're on mute.
Yeah, thanks, Doug. I appreciate the opportunity to make some comments, and I wish John was on the line. We have spent a fair amount of time over the past year with John, and he and his office have been very helpful. Doug and I have had conversations about OUD and BUP and BUP/NAL use over the last long number of months as well. Advanced Health actually puts a strong filter of harm reduction. And there's a nice dog cameo for us all. Put in a strong filter for harm reduction. And along those lines, we did, based on who's the prescriber, the ex-waiver prescriber, we did attempt drug use criteria starting last summer. Really to put guardrails around use for OUD alone and not chronic pain. So with one prescriber, two prescribers in particular, we did have a fair amount of peer-to-peer dialogue to try to curtail use of BUP products for dosing and products that are exclusively used for OUD, because those dosing requirements, Dee, as you pointed out, are different. Because of significant challenges, this is Advanced Health down in Southwestern Oregon, with our small CCO and access to care and stigmatization, we have really found that we rely a lot on peer-supported, a huge win, either with the Harbor Clinic at OHSU or now with Boulder Care, for up to almost 7 dozen of our members. Along those lines, actually our CAP just last week at our request did away with any drug use criteria, and we have in place only quantity limits. So we are concerned about how to provide guardrails unless HERC is going to change, kind of what we do with chronic pain, how to put guardrails around appropriate use. And I think I'll just stop right there.
Thanks, Kent. Any follow-up to Kent's comments related to this? So you have no PA requirements even after 30 days.
So that's been, Doug, really the only opportunity, as was pointed out under the Support Act. A CCO has no look-see in the first 28 to 30 days. And exclusively then under our PA process, it's our pharmacy teams that have really been struggling with this, and our medical reviewers. So at this point, the answer is correct. We have done away with PA requirements. Bupe continues to be on our formulary, and we have QLs only.
Is it okay, Doug, do you mind if I jump in?
Sure.
I had a follow-up, thank you, for Kent. So when it hits for quantity limit, are you still putting in place, can't be for pain? It needs to have a diagnosis of opioid use disorder?
That's correct.
Okay.
No question.
Yeah.
I think we've made maybe 1 or 2 exceptions in the past, maybe 24 months, for somebody who is having, perioperative, postoperative, short-term pain issues.
Okay, thank you. And I guess another one is, have you seen any changes in diagnosis? Because what I'm hearing from some folks outside of Oregon is that sometimes providers, in their effort to try to manage pain, and they want to get to buprenorphine, so they're putting in place, they're diagnosing people with opioid use disorder in order to get through the prior authorization process.
No,
that's the
really
concern. I don't know if it's actually happening, but that's what I'm hearing.
That's a really great question. And we actually have not seen that with our telehealth providers. We have seen that with several of our X-waiver providers who provide care for chronic pain. Somebody will establish care for chronic pain. Now 6, 12, 18 months later, all of a sudden the OUD appears, which is a Venn diagram that sometimes is really hard to sort out.
Indeed. Lisa, do we have John on?
I'm not seeing him yet. John, do you happen to be a random phone number on the QHOC meeting yet? John McElveen? I would suspect that's a no so far. Thank you, Kent, for sharing. These are kind of that kind of in the weeds feedback. The agency's kind of just wanting to know what's going on and what are those practical implications of what the options the agency could look into. I'm not saying that we are doing or not, but we're just kind of trying to hear where things are in this regard. And we know that you've been working with John in these conversations. Are there any other communities that have been hearing and or knowing there's certain providers and or patients that need these access? I mean, there's an access conversation with this for treatment, and that's really what we're trying not to obviously limit access. And so that's a consideration here as well. And I don't see John yet. I'm sure John will make himself known when he comes on, Doug.
Okay, Kent has his hand up still.
Hey, Lisa. Oh, hey, everybody.
There we go.
John, I just said, I'm sure John will make himself known when he comes to the meeting, and that is so timely, John.
That was great. I'm glad it worked out.
Let me just bring you up to speed, John. I've reminded everybody where we carried forward the conversation in May. Dee reminded folks about, again, kind of that the PA and the specific prescribing. Kent is on the line. Kent has shared some of the conversations that you guys have been working together as well. And then has shared a bit about basically the summary. Let me go back to my notes here. That there right now are no dosing requirements. There's no PA pretty much, and that they're QLs only. I literally wrote that as a quote. The telehealth providers right now for down there in their particular provider are not necessarily using OUD diagnosis leads in a I'm gonna say quote. They're not adding on an OUD diagnosis for those individuals for buprenorphine, but maybe some of the in-person providers might be. That's where we landed without you.
Right.
Is there any additional context you want to give to the conversation for the CCOs as far as kind of information we're looking for from an agency perspective as just the buprenorphine prescribing / those with chronic pain, those without?
Yeah, and thanks, Lisa. That's, yeah, and Kent is here too. I know Kent and I've had many conversations. I don't, and a couple things to continue to add context, you know, certainly I think just being transparent, and our internal conversations have gone to in the direction that really it's kind of and correct me if this is not characterizing it correctly, Lisa, but more of a kind of an informational thing at this point, just to kind of take a look and see, you know, what you guys are seeing in regards to this, because it's the intersection of lots of different things, right? We're obviously in the middle of you know, a historic overdose crisis. I think that's all you can call it. We also have come out of a time period where before we were focusing on prescription opioids and addressing those issues and things like tapering and reductions in doses. So it's sort of, it's sort of the confluence of all those things coming together, right? And so I just want to convey to people, it's really, the discussion isn't so much, I think, about whether or not buprenorphine works for patients that have chronic pain, because we know it's been done for decades in other parts of the world. I mean, that's the studies are all over the place, but it's more of a thing that goes to a few different other areas. I would put them into sort of two buckets, and that's patient care, but even on a systems management level, you know, we want to make sure, you know, we have obviously lots of folks with OUD that are also chronic pain patients. But I think really in terms of and breaking this down, you know, in serving those members, how do we do that best? You know, and is that the best way all the time? There's a clinical side, then there's kind of a system side to it. And those are all important clinical questions. And there is resources involved too. But, you know, when it really comes down to is it the best course of action for the patient? And do we need to do work together, meaning OHA and the CCOs, really about clarifying some of this and you know, making sure it really does come down to making sure folks get the care that they need, you know, because what I sense is happening in a lot of the state, and that's why we're really, to go back to what I said before, at an informational point here in the discussion, is I really want to see what you guys are seeing and what the trends look like. And I mean, do you have, you know, because I can tell you as an example, anecdotally, I can look at parts of the state where I know people struggle mightily. Telehealth has helped a lot with this, but struggle mightily with finding a data waiver provider, even though I know they're there. And I know they're providing services to some folks, probably even some in the Medicaid population. But then when you dig a little deeper, my suspicion is that what these are basically chronic pain patients who, in lieu of being tapered with short-acting opioids, due to, you know, not saying right or wrong, good or bad, but that's what the landscape looks like, right? I'm sensing that that's happening, and I think there's a lot to kind of verify that. So I think, again, I guess my ask, and again, please chime in, Lisa, and I'll stop now for comments, would be, would love to hear your feedback on this, you know, what you're seeing. You know, do you see a high rate of rapidly growing I'm just thinking out loud here as one example, rapidly sort of rising utilization of buprenorphine? what does the patient population look like? What do the providers look like that are doing that work? So it sort of helps to give us a picture because, like I mentioned, you've got a patient aspect, which should always be first, right? That's the most important thing. But there's a systems management from OHA and the CCO's perspective that's important here to think about. How do we get everybody the right resources? So I don't know if you have anything else, Lisa, or Ariel, anybody.
Well, prior to you coming on, Kent had mentioned that in his CCO's experience, it wasn't the pure telehealth providers at that time, but just an occasional ex-waiver local provider who may have just needed reorganizing, but his local clinical advisory panel actually recommended and the CCO adopted dropping any PA requirements for buprenorphine except for quantity limits. And of course, as part of that, they would be submitting a diagnosis. And if the diagnosis was pain, then it would be rejected.
Yeah, I'm aware of. I mean, we've had those discussions. But thanks, Doug, for circling us back. I think a couple of things on that. Still, like I talked about, it'd be really interesting to hear from more of the CCOs and these patterns that they're seeing. I think your point, Doug, kind of goes to what I mentioned before. I mean, there's sort of two different issues here, but they're similar. They're very similar, almost like a Venn diagram. You've got the patient care aspect, and you've got the sort of system management and making sure, and they both are together, right? I mean, we only have the approvals are only for OUD, but you also have, but I think it's fine. And again, and not really the focus of this, but it's not really, again, to say, is bupe good or bad for chronic pain? We have the answer to that. We know that in many cases, it can be tremendously helpful. And there's a history of that being done in other places. I think on the other population side, though, on the OUD side, it really opens up a bigger conversation about things like network adequacy. And I'm thinking about your comments about telehealth, Doug. No, this is local. I'm thinking this is more of a local level, in-person issue for sure. It's not so much telehealth at all. So again, just kind of thoughts and keeping that in mind too. I mean, what we're really talking about is how to serve better serve both populations, and lessen the burden on the provider too. So yeah, but really informational right now. I'm curious about trends, and we've talked about this internally too. I see. I'll stop. I'll see Kent has.
Yeah, John, thanks. And I think a number of us really welcome this conversation. One of the learning points for us down in rural and frontier Oregon is really a difference in demographics of who's seeking care for buprenorphine. So in listening to Todd Corthius up, Addiction Medicine OHSU a number of months ago, if we look at historically, who are the folks who have opioid use disorder, they tend to be older. They tend to have had chronic prescription, and maybe initially or diversion opioids. Where we've really been focusing on, if we look at our data as where our prescriptions are going, these are younger folks who are abusing heroin. And so for that reason, we really have gone after strongly harm reduction.
No, and that's great, Kent. I would just say, I really think you're touching on, and I know we've full disclosure, we've had these conversations and good conversations about it. It really does start to get into that issue of sort of serving network adequacy and serving folks. I think you make an excellent point about looking at that data. And that was traditionally the that's always traditionally been the profile. That was very true from the 2010s all the way up until somewhat recently, that you were normally talking about the people that were most at risk of development of OUD, having OUD, and also that corroborates with overdose. You had chronic pain histories, usually white, middle-aged male. What's quite interesting now, though, when we, you look at it from more of that harm reduction perspective, which is great, and really a model, I think. The demographics are changing dramatically for people with opioid use disorder. The people impacted by fatal and non-fatal overdoses is changing quite rapidly. There's a younger trending age. I'm not saying, from 45 to 17, but the average age is dropping. And I'm really kind of focused on the overdose vulnerable population and those that have suffered overdose. Trending, a more diverse population impacted, more communities of color impacted. So it is changing quite a bit. So I think that data is really interesting in terms of the picture of what that looks like down in Southwestern Oregon. So thanks, Ken.
So do you think that there's any issues? I mean, the Secretary of State recently did an audit and identified that there are a lot of shortcomings in the rollout of the prescription drug monitoring program, that in spite of the fact that there was plenty of comments previously, nothing really has changed, and the law enforcement and regulators can't access PDMP data on providers or patients without a court order. Oregon still doesn't require prescribers or pharmacists to query the database before prescriptions are written or dispensed, and they haven't expanded to collect prescription information that could be critical in preventing prescription drug abuse. So, any thoughts that strengthening the PDMP is pertinent to this discussion?
I think there is some relevance in that discussion as a whole to opioid use disorder, chronic pain, prescribing. I don't know specifically around this how much it is exactly related, Doug, because there's some of that PDMP, some of the issues around PDMP are sort of in a different context again. And I'll say, it's very clear, just full disclosure, I serve on this advisory board, and Oregon's PDMP is unique. It's unique by design. It was designed that way. Many other states, and you may or may not know this, Doug, I'm not sure, but there are many states where Oregon's structure is unique. It's unique statutorily. It's unique where it lives. It's very much like where it lives, a very public health driven thing, initiative, program, whatever verbiage you want to use, that's really is designed to be limited to being a tool for patient and provider to improve patient outcomes. So a little bit of a different angle to that than many states take, and that's really the difference you're seeing highlighted in those reports and stuff, just to be clear. But I don't know that, the idea of having a PDMP to quote catch people or to use as a law enforcement tool, I don't know that that's really specifically relevant to the issues around bupe versus chronic pain, bupe versus OUD. I think the main points are more like I've been mentioning: network adequacy. Are people with these diagnoses, number one, are people getting the treatment they need? Because I know that anecdotally, again, and this really, I think, is putting telehealth to the side, which has really expanded many times over access to buprenorphine, I think what we're really talking about is the sort of on the ground network adequacy and the impacts to the system where, you know, are we having these large groups of people that are not being, instead of being tapered, moved over into buprenorphine? And what does that impact in terms of availability of services for those who really are more on the side, on the OUD side, in terms of a more primary diagnosis? So
Thanks, John. Deborah?
Sorry, I took my hand back down because I heard John saying that the PM, I have a PDMP. There are too many acronyms. We also have the PMPDP, which I get them mixed up. So the PDMP, maybe not part of this discussion, but I know I'm interested to know because this is something I'm working on with the Support Act and the data sharing that we're going to have to do to be able to answer questions to the federal government in the next couple of years. So I plan to talk to, I'm going to turn off my camera because I think I'm getting a bad network. I plan to talk to CCO pharmacy directors in the next meeting to ask what kinds of access they wish they had that they don't have, and what is it that you can't do that you wish that you could do. If you have any thoughts on that, feel free to send them to me directly or talk to your CCO pharmacy director and encourage them to relay something. I see Amy Burns and probably others. So I appreciate hearing more.
Thank you, Deborah. I think that is pertinent, and the CCOs, if you would follow through with that, that's excellent. So,
thank you.
So, Lisa, I think we may have, we'll ask further questions from others on the call, whether or not they have questions for John or Kent, and otherwise, I think. We've completed the discussion.
I think yes, as Kent and your pharmacy, as you talk to your pharmacy folks, you find within your own structures whether you have PA criteria, what you are hearing from your providers, how they are not using your PA criteria for this particular subpopulation. That's what the agency is looking for. Whether you bring that into your CCO pharmacy directors meeting or you bring that in through John McElveen or myself, that's really kind of what we're trying to do, some information gathering, so we can support the access and the care that really needs to be delivered. So either one of those avenues is really CCO pharmacy directors through Dee Weston, or John or I through QHOC is really what we're looking for. And there you go. There's everyone's email. It's also on the speaker's contact sheet. Kent has shared kind of at least one experience of one CCO, but again, we're looking for what's going on across the state, and we definitely don't want to cut off access to any one part of the state for the rest of the regions. So we appreciate hearing from y'all.
thanks, Lisa.
You're welcome, John. Getting warm in here, I decided. It's starting to kick up warm outside. So what items from the floor will we have here, Doug? We had a little bit of open time, which is always a luxury that we don't get.
Well, actually, many times in the past, we've not had a meeting in July or August. So actually, we used to get a lot of time then. But I think we'll open it up. Any questions to deal with now, or maybe suggestions for future agenda items? Put it in the chat box, or raise your hand right now. And otherwise, I think that we can adjourn early and have a much more leisurely lunch for those returning at 1 o'clock for the afternoon session. Well, thank you very much. Have a great summer, and we'll see you in August.
Thank you, everyone. And just as a reminder, please just dial back in at 1 o'clock versus putting us on hold. So we'll see you all back at 1 for the quality session for those that are joining. Thank you.
Thank you all.
All right, bye.
Someone joined for a couple seconds, so we'll just go ahead and get going. Hello, I'm Lisa Bowie. This is the Quality Health Outcomes Committee Quality Performance Improvement QPI session for July. I apparently have a frog in my throat, so I'll try and pardon the cough. I have black hair with a beach scene behind me. I'm the Quality Improvement Director for OHA. Your co-chair or your chair for the QPI session is Laura Matola. Laura, you want to give a shout out?
Hi, I'm Laura Matola from All Care House. She, her, and hers, and I'm in our guest bedroom. So you're going to see dragonflies on the walls.
Okay, just a couple housekeeping, and then I'll get into some of the announcements that we've kind of addressed through the chat string as well. Just as a reminder, please keep your phone muted when you're not speaking. If you're having some issues with the mute button on your Zoom profile, then try and use *6 if you're calling from a phone. If you would like to try and you can either put a comment in the chat string or you can use the raise hand functionality on the reactions button on the Zoom menu. And then if you can, please try and remember to state your name and the organization you're from when speaking. That's really just kind of helpful context. Although this is a smaller group, so maybe we all kind of remember each other, but it's helpful just to say, hi, Lisa from OHA, just for when we're trying to get into the dialogue part of the conversation. Today's agenda, there's not a lot of slides. Actually, there's no slides for the QPI. When I say not a lot, that means none. So you didn't miss that. We have on the agenda Exhibit I, so we're bringing that forth from the quality assurance team. So we're giving an update again on the Exhibit I. So Carrie and I'm gonna say John. I wanted to say Jeff, and I don't know why I was gonna say Jeff, but Carrie and John from the QA team will give that update. And then we'll carry forward the statewide performance improvement project for SUD design phase forward as we're nearing that. So before we go into any of those specific topic areas, I'm going to cover a couple housekeeping announcements. So I'm going to cover performance improvement projects first, and then I'll cover TQS. So performance improvement project. Number 1, when and what do you have due and when do you have it due by? July 31st. That's, I don't know, 20 days away if you do math. This month, the end of this month, July 31st, you have due. Yes, you have your statewide PIP annual validation external quality review. So EQR validation on the HSAG form for your mental health access one. You should have received an email from, I believe, Jennifer from HSAG directly as a reminder of the steps as well as the forms, as well as where you can access those forms on the state website. So she attached them to the email. She referenced the hyperlink where you could get them. And she told you, here's what is going to be validated for mental health access on the July 31st submission. So mental health access statewide PIP is being submitted July 31st. It is being submitted through the OHA contracts deliverable email box. Additionally, on July 31st, your quarterly reports are due, for your other PIPs, your CCO specific PIPs. They all deliverables, whether they're the HSAG external quality review form or the CCO specific quarterly report, progress report form, all deliverables come into that same CCO deliverables email box. All deliverables email are also referenced, and I'm going to drop that deliverables email box into the chat string as soon as I find the email. Because if you were listening to this morning's session, you would have heard about how the state of Oregon, not just OHA, is changing their domain name for emails. Just like the @ everything after the @ symbol is changed. And so those email addresses, we want to make sure you have the proper email address. The Jenny Montano email reminder at least regards to the state email address or the statewide PIP mental health access one. They included the correct updated email address. So I'm going to drop it in the chat string here in just a second. And then you'll be like, oh, okay, cool. And it includes the hopefully. Yeah, I'm just going to copy it right now and I'll put it in the chat string. That's the one that's due July 31st. All of the forms, all your deliverables go to this email box. So quarterly CCO specific tips, reports, progress report forms are on the OHA PIP website. HSAG, mental health access, statewide PIP, annual EQ validation form, July 31st, both of those. All forms are on the website of OHA. Any question about what's due on July 31st for PIPs? Since I know I have some dental plans also on this call, DCOs have a deliverable also on July 31st. And you too got a reminder from Jenny Montano on July 31st regards to your DCO specific PIPs. And you too have your own email box of where those go. So you would have gotten an email from Jenny Montano at HSAG regards to your deliverable for DCOs. So if you have any questions about that, you can email myself or Jenny Montano as well. So DCOs, you got your email. CCOs, you got your email. They all came from Jenny Montano from HSAG. DCOs only have one deliverable. CCOs, you have two deliverables for PIPs. You have your CCO specific PIPs and you have your statewide external quality review validation one. Okay, the second or the third thing you have related to PIPs, CCOs is the SUD statewide design phase. That due date is August 31st. So you have due date July 31st, and then you have a due date till August 31st. That is also referenced in the Jenny Montano email. And maybe I'm saying Jenny's name wrong. Hopefully I'm not. Sorry, Jenny, if I am. So August 31st is when the SUD statewide PIP design phase is due. So you really, 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 really want to read the Jenny Montano email that was sent on, well, I think it was like the end of June. And she also references the presentation that she did at QHOC at the end of June. So it goes over a slide deck too. So if in fact Jenny's email and the slide deck can't be found, or you have questions from either one of those, then drop me an email. Jenny or I or Chris Hartman are happy to walk you all through it. So July 31st, mental health access, CCO specific PIPs. August 31st, SUD. That's the basic gist regarding PIPs for CCOs. Any questions from CCOs or DCOs? Do statewide PIPs only have annual validations or are there quarterly reports? There are quarterly reports. Yes, Cassandra. You should be submitting quarterly reports with your statewide PIPs, in addition to your annual validation on the HSAG form. You do not have to submit a quarterly report form when you submit an annual validation form. So you don't need to submit two forms on July 31st for the mental health access PIP. You just submit the annual validation form in replacement of a quarterly report.
So thanks, Lisa. This is Cassandra from Pacific Source. So does that mean we'll also have to do a quarter 3 report for the statewide PIP for mental health access in October? Because I'm just looking at the validation schedule, and the report for the HSAC report only has 3 spaces for 3 measurement periods. Are we just asked to do a progress report update under that to submit to OHA each quarter?
Sorry, Cassandra, can you repeat your question?
Yeah, I understand that there is on 731, we have our annual validation, but if there's an addition to that, there's quarterly progress reports for the statewide PIPs. The forms are a little bit different. So we don't have like the quarterly update review space like we do with the OHA template. So I'm just trying to verify that we still have to submit quarterly the HSAC forms to OHA.
Not the HSAG form. No, you would use the OHA progress report form.
So we have 2 forms to fill out for the statewide PIP then?
Yes. You use the HSAG form only for the annual validation.
Okay.
That is only for the annual. And then for Amanda's question, which is completely separate, but I'll get to it, Amanda, as soon as we make sure Cassandra's good. The EQR validation is just like, think of it, it is what it is, which is a third-party validation, just like 100% external quality review validation. We eliminate the progress report status of the statewide PIP when you do go through your third party, just because no need to duplicate there. And there's enough detail on that. So we're not going to have you do that part of it, you know, like submit a quarterly OHA form and a PIP validate, the annual PIP validation form on July 31st. But in essence, I could make you do that, but I'm not going to make you do that. So we're just going to use the annual validation at that same point. And then Cassandra will let that simmer and sit. And then if it's not clear, you can raise your hand, or we can drop another email, or anyone, not just Cassandra. And to Amanda's question, will there be guidance for completing steps 1 through 6 for HSAG's EQR validation for the SUD statewide PIP, which is going to go through validation for the design phase, which is again the earlier steps of the validation for the mental, not for the SUD? The answer is yes. So SUD, which is where we'll have the latter half of this QPI session, I will be working with Sarah Adelhart, who's been working on project managing this particular SUD design phase, and we will consolidate the notes, the SurveyMonkey results, the conversations, internal and external, that has led to where we will have landed for SUD topic and measurement, and we will put forth a summary document. That summary document is to supplement wherever your conversations have had internally as well. That those 2 things, your notes, your committee, because I'm not in your quality committees inside your CCOs, and my summary document, OHA summary document of internal and external meetings, is what you use individually to fill out your validation document by August 31st. So we will be filling out that summary document, Sarah and I, shortly after, well, not after this meeting, but after we land with leadership and you all. I'm hoping very soon. So to Kristen's question, so that answers Amanda's question about, yes, the agency will be putting forth a summary document for SUD statewide PIP, similarly so as we did in the past for mental health access. You do not copy and paste that, but you use it to supplement your existing conversations in your own CCO, in your own region, et cetera, et cetera. Kristen, to your point, no, you do not submit a quarterly report for mental health access in July. I'm not going to make you double report. You just do the EQR validation. I could make you, but I'm not going to. So the answer is no. You do not do a mental health access quarterly report.
Thanks, Lisa. I'm sorry, this is Kristen from HealthShare. Thank you. But then in October, we would submit a quarterly report for that one, right? We'd get on the regular schedule.
That is correct.
Okay.
That's correct. That is correct. Jenna, I see your hands up.
Kristen just asked the question. I just wanted to make sure that essentially, because we're doing this HSAD validation, that actually will now start kind of transition us from design into our actual kind of implementation. And that's why starting Q3, well, actually Q2, we would start doing the quarterly.
Yes.
Quarterly updates. So October 31 would be our first quarterly. I think I just had the moment of panic of thinking,
well, and technically we would have
been submitting quarterlies this whole year, and I haven't been. So that was my panic thought. But I think you answered the question.
You knew exactly the answer. And so, and by the way, you sound really like you're in a tunnel / underwater, Jenna. So I don't know if it's a speaker thing. So Laura's giving me a head nod visually. So there might be something going on with your sound system. And in the past, so let's just go back, not from a past, yes, David's giving me the echo was awesome. But when we get into the intervention stages of quality improvement work, right? So not the design phase. So obviously when we're designing the work, which we're all doing right now with the SUD, there's not a lot to report. I mean, we all sit there and we're talking and we're trying to think through and we're looking at data and we're just like, okay, what's the most sense for where we can all go together, get collective impact, right? But what, and then we get there and we do break like we're a team, and then break and we're going to go back into our respective communities and go do some PDSAs and test some intervention. That's when there's a lot of more individualized community-based work happening. And that's when y'all report to me. And if in the opioid work, that's when, you know, some people did some regional work and y'all got together. And then we, the agency, were getting some real direct, more real-time quarterly reports. And it was like, okay, we need to provide X, Y, and Z and put this back out to you all, or you were directly asking for different things. Well, those quarterly reports is how we partner to do that. No quarterly, you know, plus it's just the mechanisms of, you know, quality assurance, checks and balances, all that. So that's what those quarterly reports are for as well. So yes, that's where those quarterly reports are going to start coming into play now. And that's exactly where Jenna was going. And that's where they'll come in at the what do you call it? The October 31st. And technically, we probably should have had them come in earlier. I've just been in COVID duty / other duties as assigned. So I didn't really get you all there. But for those that have been around for a long time, Jenna, a few of you, you're like, oh, this sounds vaguely familiar. So, but Cassandra, who might be a little, you know, newer, she's like, wait a minute, is this? And so she's just trying to figure this out from a deliverable standpoint. So it totally makes sense, Cassandra. Cassandra, your hand's raised.
Thanks, Lisa. Thanks for the clarification on the quarterly reports. For those, are we going to receive OHA data on a quarterly basis to use for those reports? So we'd be expecting to see that?
You should be getting our data regularly every month from us. Okay.
Well, thank you for that.
So if anyone's not getting their data from us monthly on a rolling 12, you should drop me an email.
Hi, Lisa.
Because I know people are trying to get. I know some people. I know some of you are getting it because some analysts are talking to analysts about issues with data. So y'all should. If you aren't getting it, you should let me know.
Lisa, is it being posted to the SharePoint where like the CCO metrics and other data is posted?
Yes. I handed over to analytics team who regularly distributes your dashboard data on the last Wednesday of the month thing. I think it's historically, however, we've handed out your dashboards, the CCO dashboard metrics, CCO incentive metric dashboard stuff. And I know there's multiple ways at which CCOs access data within this agency, because there's a whole host of data, your enrollment file data, and then this goes through the CCO incentive metrics dashboard team. So the PIP data, whether it's mental health access or whether it will be your SUD, it all goes through the CCO incentive metrics team portal method. I don't even know what that portal is, but it's the secure file transfer portal of the CCO metrics team, incentive metrics team, not the enrollment team, not the other, wherever other teams there are, because I know there's at least 3 platforms.
This is Cassie from Trillium. I haven't seen anything come through, and I don't know if anyone else has seen any come through, but I haven't gotten anything, and I'm on the SharePoint looking at like all the most recent editions, and I don't see anything since we got the yearly file in April for measurement year 2021.
Okie dokie. Lovely. I'm gonna go ask. Okay. Hang on. Let me write a post-it.
But I do see all the other, like the alert file, the CCOmetrics dashboard, all that's in there, but the only PIP information was April 29th.
If anybody, who was I just talking? Someone was just talking about their data with this person. Okay, I will look into it. It should be a rolling 12-month every 12 months. I will find out. And thank you for letting me know, because the assumption is you should be getting this piece. Pacific Care is a no, IHN's a no. I swear, John and Carrie, we will totally get to Exhibit I, but these are very clearly some things that we need. Okay, I will talk to the analytics folks and find out the rolling 12 months, and confirm that I believe, again, they should be through the CCO incentive metrics dashboard release portal. Okay, so yes to the quarterly. Yes, you should be getting a rolling 12-month. It should be on, I believe, the last Wednesday of every month. And yes, it will be, and I'll do the SUD stuff when we get there as far as, but that's I believe the intention as well, as SUD statewide PIP will be the same. Once we get to the SUD statewide PIP topic, we'll have that conversation. But for mental health access, that's the intention. That was the decision, and I thought the practice, not like hypothetical, like it should have been so. Any other questions about PIP? Okay, I'm going to go to TQS now. Transformation Quality Strategy. Just again, as a reminder, if you haven't requested your feedback call with the agency, then you can do so if you like. They are optional. Someone created a really cool smart sheet, and it has the drop down of all the holds, appointments, and you can just pick a hold, and it magically appears on the OHA TQS leads calendars. It's kind of slick, which is just even more advanced than I knew how people can do things. We will be doing, and this has come up just during a couple of the calls that we've had so far, so it's just a good blanket announcement for folks. We will be doing the TQS webinar series in the fall. So I know some of y'all had mentioned that in the past, where we used to do them like in January, February, and then we moved them up to the fall. When I say fall, we mean like late September, early October. We're going to try and aim for that again. I know y'all have a lot of fourth quarter things, but I believe CCOs are the people. Y'all asked us to do it in the fall, just for your planning. And so we're gonna really push our subject matter experts to try and achieve that again, late September, October, TQS learning series for planning for 2023 submission. So we'll work with our project team and put out some hold dates for those. So as soon as we know those, we'll let you know. But at least we've declared that, yes, it will be in the fall. So you can plan for that. What else with TQS? Yes, it's still here. No, it's not going anywhere. I'm working with Laura, your chair, to talk through, you guys raised a topic area of MEP and TQS. We were not able to get that squared away for this month. We'll see if I can get a conversation and topic presentation for next month, but we heard that suggestion, and we'll see if Laura and I can work with the appropriate subject matter experts and bring that forward for next month. And then we will still try and plan a peer learning, but most likely that might be September, because August peer learning, I don't know, it's coming, it's going to come up pretty quick, because August is like August 8th. It's a quick QHOC. And I don't know, Laura, I think August 8th seems like it's just around the corner, that it might be too quick to plan that peer learning for that month. We might want to put it in September. Your
good.
thoughts? Okay.
I like that.
Yeah. Whenever a QHOC follows on the 8th of the month, that is the fastest one. It's the earliest one of the second of the Monday. That's TQS. So those are the main things. Is just the webinars will be in the fall, as you guys have suggested in the past. Any questions about TQS before we turn it over to Exhibit I? Okay, I'm going to turn it over to John and Carrie from the QA team.
Hello. When I was thinking during that conversation, we certainly appreciate the need for data. So no worries on the start time. So here this afternoon, and first I'll stop and introduce myself. My name is Carrie Williamson. I'm a quality assurance and compliance specialist on the QA team with HSD. And then I'll let my colleague John introduce himself.
Hi, everyone. I'm John Levere, compliance data analyst on the QA team as well.
So we have been, over time, coming to this group with updates on work that we're doing around Exhibit I reporting, changes to that reporting, and we're here to give you an update this afternoon, get some feedback from you. So wanted to start with some conversation around implementation of requirements. Well, the requirements are in contract, but implementation of those requirements in the reporting tools to come into compliance with House Bill 2517, which was around gathering information on prior authorizations from each of the plans. So we have mocked up a draft revised log to share with you. And Jennifer, would it be all right if I shared my screen? I've got the draft pulled up.
Yeah, I will give you permission to do that. Just
Awesome.
A moment.
Thank you so much.
Sure. Okay, you
Yeah,
should
and
be able to.
Go ahead.
At a previous meeting, we had discussed plans to streamline reporting and move more towards CSVs. And so just to frame, that's kind of what we had in mind when re-envisioning this template.
Okay, are you all able to see the template, the draft template? John, are you able to see the template on the screen? Okay, cool. Thank you. Thank you. Okay, so figured we'd just walk you through our proposed changes. And again, this is draft. Our hope is to get feedback on this. We're also going to be taking this to the contracts and compliance work group meetings because we recognize that there are there are lots of different folks involved in using the grievance and appeal data, and we don't want to miss any feedback that would be critical for this work, and we don't want to interfere with how you use the information that you gather and put forward in this log in your own internal kind of use of the data in your quality committees and that kind of thing. So you'll notice right off the bat that this is already looking much more streamlined, taking away the formulas and the macros, and because John will be able to do the bulk of that analysis on our side, on the OHA side. You'll notice down at the bottom that the summary tabs are missing. And so I had touched on a little bit, wanting to make sure that we wouldn't be interfering with any of your internal analyses. So wanted to get a temperature check from this group. If we removed the summary tabs, specifically the grievance summary tabs, from the log, the quarterly log, would that interfere with your ability to complete the quarterly analysis that is also due to OHA? And I believe I have that here, so I can kind of refresh your memories around. So this here that is due and currently is pulling from the grievances summary tab from the log. If we remove the log as we're if we remove the grievance summary tab as we're proposing to do in this draft template, would that cause any trouble for your teams in terms of completing this analysis, or any other kind of analysis that you use internally? And just pause there for consideration and some discussion.
Hi, this is Laura from AllCare. We actually do utilize those summary tabs because it does help us, and it just takes one step out from us having to tally up all of the complaints and stuff by the categories. So it is actually very helpful for us to use that when we're doing the narrative portion.
Okay, and certainly,
Carrie, you're also getting in the chat box that Alexis likes the summary tab.
Okay, thank you.
And then David says it looks good. Oh, you're also getting why CCO uses the tab as well.
Okay.
Specific Sources uses it too.
Okay, and this is why we are coming to this group to check in. We are certainly sensitive to not wanting to add to, or create any administrative burden. So if folks are using that, that's something that we will certainly take back and consider really significantly before making any such change. Okay, so all right, and if folks, if anyone else uses that, if you want to indicate that in the chat, just so we can kind of get a record of who is making use of that summary tab, that would be fabulous. Okay, so we'll just move along then. We mentioned the House Bill 2517 implementation. This is the direction that we would really like to head in for the quarterly log and the PA reporting, and those requirements are in contract. So one thing that we also wanted to check in with you about is this PA ID. So we will be at some point requesting, a record of all the prior authorizations, and I know that could be a lot. That could be a lot. So again, wanting to get that temperature check, and then having a PA ID attached to each prior authorization, so that we would be able to track that PA through the NOABD log portion of the log, and track that through the life cycle of the grievance and appeal system. So pausing there, letting that settle in, any feedback on the lift associated with attaching a PA ID to those prior authorizations for each of the plans.
Is there, this is Laura again from All Care. Will there be a character limit to that field?
I'll let John address it. He's shaking his head no.
Okay, because I know ours that auto assigns them are very long, and I want to say they're like 12 to 14 characters long.
That is good to know. Yeah, really our purpose is to be able to track from beginning to end, like the progress of each prior auth. And so we recognize that there's probably not a lot of consistency between CCOs as far as format for those PAIDs, as long as they are unique for each CCO. That should get us where we need to be. And yeah, no character limit for that.
The primary diagnosis code, is there anything here that might cause heartburn in terms of reporting? Anything we?
We're only asking for the primary diagnosis code. That shouldn't be too much of an issue. It's if you're wanting the second, third, fourth, and so on, which will get more complicated. And then the service type, I'm just assuming you're going to be mirroring what is currently set up for service types. That's not going to be changing. The other last comment or question I have is, have you guys looked at what HSAC requires for parity and tried to align the two so that we only have to develop reporting once for both types of deliverables?
That is something we will look into before rolling this out. That's excellent feedback. Thank you.
Hi, this is Jenna with YCCO. Hopefully I'm not sounding like a robot. I do have a headset set up now.
No robot, although it did sound pretty cool.
For the primary diagnosis code, what is the purpose or what's going to be the use of that data element? Because I think my question sometimes is, there's sometimes multiple diagnosis codes that are associated with a request. And so not really understanding why we would include just a primary diagnosis code, because there may be, second, third, tertiary DX codes that might associate with that denial or approval. So just wanting to call question for that.
Yeah, that's a really excellent question. And we're trying to balance, reporting that is useful and kind of gets us where we need to go in terms of that House Bill 2517 and understanding the medical necessity piece. And then I think you make a really excellent point around the levels of diagnosis codes, also, containing really relevant information potentially. So I think that may be something we need to take back and think on a bit more, or if someone from this group has some thoughts around, getting to the right level in terms of information, again, to track the medical necessity piece, and to be able to complete, robust analysis on what types of PAs are being approved, denied, the background and situation on those PAs, so we can be looking at those trends. But again, trying to balance that with reporting realities and being realistic with what is doable for the plans. And did that kind of answer the question in terms of why we're looking for that information?
Yeah, and I think just having a little bit more kind of discussion, because I think DX and pairing and all of that, it gets really, really tricky. And so I think I was just trying to understand, this can be a pretty significant amount of data. And so, trying to understand what it will be used for and how it will support the Exhibit I reporting, I think is really where my kind of question was coming from. There are a variety of other places, as I think it was Laura pointed out, mental health parity that we're submitting PAs. We're submitting PAs for other types of audit activities. And so, there are different mechanisms by which we collect all of that data. Another question that I did put in the chat before I hopped off is that, will this cover all of our benefit lines? And I think specifically my question is around pharmacy and RX, because, you know, PAs and pharmacy pieces get even more tricky. And so for physical, behavioral, dental, there's that piece, but, you know, RX is kind of a beast of its own. So I would just call that out and just question that data point for all PAs.
And the intent, again, really to get in alignment with those House bill requirements would be across all of those lines. So that, again, that's really good feedback, that pharmacy piece may require some special attention to think through. In terms of the reporting from the plan side, what particular boundaries or limitations or challenges might there be around reporting on that info that would be, you know, important for us to be considering?
You know, I think since, you know, a lot of medications are point of sale, I can't necessarily, I'm not an expert in all of the challenges exactly, but I do know that when it comes to pharmacy related data, it is a challenge in just tracking, because we cover benefit based on formulary. And so it's, yeah, it just gets really tricky. I don't know if any of my other colleagues want to speak to the more detailed challenges, but I know we've struggled year over year anytime we try and aggregate some of that pharmacy PA activity.
Okay.
This is Laura Matola from All Care. I kind of want to go back to what Jenna was saying, though, about the primary diagnosis and then your response. If you're looking at that primary diagnosis to see if we're approving or denying, one of the things that's going to be really hard is that if we're approving something that is a below the line, you're not going to see what the comorbid condition is that caused it to be a covered diagnosis. Same thing if we're denying something for below the line, you're not going to see that there were no other comorbid conditions. So that's going to be, if that's one of the areas you're looking at, just having a primary diagnosis is not going to call that out for you.
Yeah.
And then also,
go ahead.
Oh, I was just going to say Deanne had her hand up, but then it went down. So I just want to be respectful that she was also has had her hand up and down.
Thank you. Yeah, I think this is Deanne Carr with YCCO. No, I took my hand down because I thought, maybe I'm getting a little too far into the weeds, but differentiating primary versus principal diagnosis and what's really being looked for. But I'm assuming that the standard will be to take the first position diagnosis irregardless. So like I said, that was probably a little too far in the weeds. That's why I de-handed.
I'm still making a note of it. Something for us to be thoughtful about. And Laura, coming back to your point around, pairing and line placement. Earlier in the conversation, we talked about those service types, and at this time, using the current service types and the current codes as they are, and moving towards more nuanced codes and for the reporting on the logs, so that we can get down to the level of pairing and that kind of thing. But that will be, I think, a body of work that we'll need to take on a little further down the road. So that makes me think we probably need to take the primary diagnosis reporting category back and think on that a little more, and the timing on that implementation. And Lisa, I see you've got your hand up, and then Alexa, how are we doing on time?
Oh, no, we can carry forward this conversation. This is a rich I think that's exactly, I'm having a little heartburn with this primary diagnosis code conversation, and I'm going to David's comment of how do we intend to use this information. I'm also thinking through, this is just the PA, because there's so many implications with this, because dental's right.
Mm-hmm.
This is just for PAs, denials.
this is for all PAs. This tab would be all PAs. A lot.
And to only use the primary diagnosis? I don't know. And John's like, what are you thinking, Lisa, from a data perspective? He's like, what the hell are you going to tell me? I can see him right now. He's like, what are you thinking? I'm trying to think of.
Yeah, so I think remembering back to when we were having meetings to discuss this, so we wanted to drill down a little bit further than service type. We felt service type didn't quite get us to the level where we wanted. And so we were considering using CPT code or HCPC code or diagnosis. And I think we landed on diagnosis because every PA has a diagnosis, whereas they don't always have CPT or HCPC. That's my recollection.
So this is obviously one we're going to need to stick a pin in and have some more conversation before we do anything formal with this one. So again, appreciate this group and the thoughtful feedback. This is why we come.
Marie, to that point, Marie, are you saying dental doesn't have a primary diagnosis?
Correct. We
That's
don't
what I thought.
use diagnosis codes at all.
That's what I thought. So that's, yeah, because I'm trying to think of, and I'm trying to think in specialty care, right? So when I did specialty care, sometimes the primary diagnosis that we put through wasn't the primary care. Like when you're doing a PA for like a MRI, that may or may not be the most relevant. So for the PA denial, that would be fine. But for some of the other type of services and the pairings of the primary diagnosis with the service PA that you're requesting, that may or may not be it may not work beyond the fact that oral health just doesn't do diagnostic, doesn't do diagnosing. So there's a couple of things that Carrie and John that we're going to need to think through on this. And then what we might want to do is think through what those questions are and come back to this group, but we've obviously just raised a few. And so my heartburn hasn't subsided yet, but I don't think there's like an antacid pill to fix it yet either. But we'll find one. We'll find that easy button. I'm sure there is.
We'll get there. We'll get there. And so the for Q3, thinking about the House bill requirements and what we need to do, to get things in order there. This is obviously not going to be ready probably for Q3. There's some stuff we need to work out here. So using the current log as it is, implementing a spot on the setup tab for the plans just to report the number of prior authorizations total across all lines of business, dental, physical, behavioral health, just the total PAs. So that will be coming for Q3 so that we can then begin to report on the elements required in House Bill 2517. Okay, so this PA look. So it sounds like the PA ID won't be too much trouble. Wasn't hearing too much there. Using the current service type, service codes, which I think a conversation will need to be had at some point around whether those are the right codes, or we want to dig deeper, and I think we will, but that's a conversation that will be coming, and then taking back the primary diagnosis code and really thinking through when this does get implemented, what that should look like. So again, appreciate the conversation, and I'm looking at my notes to see, John, was there anything else? And then the summary tab, it sounds like that is being used pretty heavily across the plans. So that's another one where we're going to think really in depth around what would the benefit be. Is the juice worth the squeeze? Removing that. It sounds like if you all are using that, we don't want to make things more challenging for all at this moment in time. So.
one thing I was just going to mention is with the summary tabs, that will make it so this template is kind of guidance. I think if plans would prefer to send us CSVs with this information as separate reports, as opposed to like a tabbed spreadsheet, I think that is doable. With the addition of the summary tabs, that will make it necessary to remain in a spreadsheet format for those plans that utilize the summary tabs. So I just want to call that out.
I'm going to go ahead if we covered everything we needed to there. John, anything else we were missing? I think we got it. Okay. Any other? I'm seeing the chat now. Thank you all. Okay, so and then the pharmacy PA challenges. So we're going to take that piece back, especially and do some more thinking there to figure out what that could look like in the future iteration of this reporting. But again, for Q3, reporting on the total number of PAs, and then we'll be able to back into some of the 2517 requirements, and then we'll be looking at full implementation of a template that we'll be bringing back to this group to review for Q4.
Great, thank you. The other thing, Carrie, is we'll maybe Jennifer can get you some of the chat strings if you haven't copied it over, some of the comments that are all up in the chat string here. There's a lot of good things in there. So Jennifer, if you can download the chat string and then maybe get it over to Carrie and John, that'd be great.
Thank you so much. Thanks everyone for your feedback and time and attention. Appreciate coming to this group and the good, robust conversation.
Thank you. Jenna's like, yeah, Jenna, do you want to go ahead? Yeah, you can help us try and link it. It's been a fun project that John, I know, is loving.
Yeah, hi, Lisa. Sorry. I mean, I just was kind of thinking through all the details, and you know, one of the big things that you know, we've struggled with is kind of looking at all of making sure everything matches up between NOABDs, appeals, and PAs. That's, you know, there's lots of different nuanced pieces, and so that was my question. If we're going to have, you know, the ability to report out on this, is there a desire to incorporate in the PA log side an outcome? Because it'll be a challenge to link it with the NOABD and or the appeal without some kind of connector. Yes, you'll have the patient ID number, but you know, there are multiple services that an individual could request and or be denied or partially approved or denied. And so just calling that out as you go back for consideration on how to link the PA to the actual denial NOABD, and if it's appealed, and what level or type or portion of that request, you know, might have been approved or denied.
And then, so and I see, David, your follow-up. And so, yes, that is the intent at this time of that PA ID, is to link the PA to the NOABD through the life cycle of the tabs in the log. So.
Okay. I guess I was thinking that the PA ID would actually be an identification number that's internal to our system, which isn't necessarily tied to an NOABD, at least as far as I know, in the current reporting structure.
In your systems, are you able to see that the NOABD is connected to a specific PA?
Yes, we can do that, but that's only within our own systems. You wouldn't be able to see that necessarily in our core systems. And I think that's where I was, you know, if you're going to be able to do analysis, you won't know or be able to see that an NOABD or an appeal was linked to a specific PA. We can see it in our core systems, but again, from an external analysis, I am not seeing a way to be able to do that.
And I think, so our intent is that PAID would be through the NOABD tab and the appeals tab. So there wouldn't be a PA, so on the NOABD tab, there wouldn't be a PAID for all of the NOABDs. Like, of course, for the claims NOABDs, there wouldn't be one, but if it was an NOABD attached to a PA, then in the future state reporting, the PAID would be included with that in the same line as that particular NOABD, so that we could then trace that through the PA tab, the NOABD tab, and then the appeal tab. So it would be a smaller pool throughout each of the tabs, but then to track that PA through the life cycle if it did ultimately come to an appeal.
Okay, so the PAID would transcend all the other tabs, the NOABD and the appeal tab.
Correct.
And that's where the status of if it was a full denial, partial denial, or even approval would be a new status, because we've not historically, well, we wouldn't have that. Those wouldn't carry over to the NOABD tab or the appeal tab. Okay, yeah, I think, yeah, it sounds like that could work. Okay. Thank you.
Thank you. That was good to think through. Okay.
Yeah, I think that's what David's also, if you look at the chat string, I think that is correct. Thank you, David, for following the logic or putting out the logic, and John's confirming it.
Thank you, everyone. Yes.
Just making through some of the finer points.
Mm-hmm.
Any other questions for Carrie or John? We'll take back some of those other finer points, think through some things, obviously some oral health points, some of the summary tabs, and then you kind of heard some of the timing. We have a little bit to think through, but it sounds like some of the pieces are starting to click as far as what the vision and trajectory of this is. Okay, well then, thank you, Carrie. You guys are more than welcome to stay, John, if you'd like. We are going to transition to SUD, substance abuse disorder, statewide PIP design. Let me see if Sarah Adelhart is on by now. Sarah, are you here? Just for the good of the order. Sarah's not here. Dana Peterson, are you here? Oh wait, Sarah, I just saw your name. I think I saw you there. Maybe you're on mute still. I'm here, but having audio issues. Okay, well, Sarah's here. So Sarah has our note-taking functionality. So I just want to make sure we're covering things. Frank Wu, do you happen to be on? I'm not sure if you're even working. I just want to check from who's here from OHA side. Let me check the good old participant list. Okay, so where we left off, have had more internal meetings and we've had an external meeting. Thank you for those that came on to the last OHA external meeting. As a reminder, this is the SUD statewide performance improvement project. Your validation for the design phase is August 31st. I am hoping to have OHA leadership sign off shortly, and I was not able to meet with more OHA leadership before today, but I have given folks a heads up of where the direction is at. Basically, where we are looking at is the initiation and engagement and treatment topic area, which is currently, as of right now, the CCO, one of many CCO incentive measures, being the statewide performance improvement project for SUD. There are several considerations and factors into that decision point. This is not final. This is not done, but it is looking in that direction. There are several factors for that. One being that this particular SUD statewide performance improvement project is and does go through external quality review validation through HSAG, which does mean that it goes through the CMS PIP protocol, which does require measurement validation. Measurement validation requires a measurement that can be validated. And measurement validation requires a whole lot of things that, let's just say, are not necessarily on the transformational side of measurement. So, you know, we can't do, you know, you have to have a numerator, denominator, those kind of things in the measurement validation part of it. So that's where we are in that kind of conversation. So workforce and some of those transformational areas that we may want to work in that can't be measured necessarily at the CCO level are not necessarily allowed in a protocol type manner. So that's where the most recent update, again, not approved, not final, but most likely where we're going. The conversations where the CC, where the internal agency is at, is where within the IET metric, because IETs, I mean, it's not solving world hunger, it's not all of SDOH, but again, within validation and CMS protocol, there's still a pretty broad focus of initiation and engagement. It's implied with the word and. There's initiation and engagement. And so we have to now open this conversation up with you all and CCOs. And I've had this conversation with internal staff, subject matter experts, as well as our behavioral health folks, CCO, public health, et cetera, to talk about the alignment of initiation and engagement to OHA priorities as well. So the conversation here at QHOC will be initiation and engagement. You all have been working on initiation and engagement. Well, one, we've been reporting this measure for some time as part of our state plan measures. State plan measures meaning part of our 1115 waiver measure set for some time. And then it became an incentive measure right before the pandemic, which we understand, obviously the pandemic has put a damper on some of the improvement work. So yes, it may be on the measure set, incentive measure set, but we understand obviously 2020, you know, what happened with the pandemic, et cetera. So the IET measure, where and what y'all have been working on in the community with IET, initiation and engagement, the conversation that I'm having internal with staff is there an opportunity with the statewide PIP, because we know IET as a whole is the incentive measure, is there an opportunity with the statewide PIP to focus within the IET in any one part of IET, or not? We can keep it broad, or do we want to focus? And so that's still the conversation equally that I'd have here with you all at the CCO external avenue. So I will hold the floor now open for that conversation. So today's conversation is all about IET, and where would you, if you had the space in knowing that it most likely will be the SUD statewide PIP, thinking a target population of 13 and older, is there reasoning for those who are working in your communities around this metric for some time, that what you're seeing in your communities, because I have the data, but the data only tells me so much, so I have quantitative. You're going to provide me the qualitative here right now, here in a sec, around initiation versus engagement to narrow focus, or you can equally provide me input as to why we'd keep it broader and keep it initiation and engagement. And you can use your reactions buttons to raise your hand or go on camera, or you can put it in the chat string, whichever way you want to go to provide your thoughts on the matter.
Deanne here with YCCO.
Hi, Deanne.
Hey, you know, I think that broader is better, especially as we wade into this. I think it's we don't know what we don't know, and there's a lot of opportunity for lessons learned if we leave it wider and allow a little more creativity amongst the CCOs. Then we may discover opportunities that we wouldn't have otherwise if we'd been more narrow. Did I stun everyone into silence, or having my audio go out?
Oh, I didn't double mute. I said, thank you, Deanne. I just been talking to myself. But you did you did stun everyone into silence. I said, thank you, Deanne. And then I said, and everyone else must be so just enamored with your thoughts there. I said thank you, and I did also maybe make an assumption that everyone's well aware of IET, the measurement, and that just as a refresher, there's 3 sections, or there's 3 populations within the IET measure beyond just the age populations that I referenced. There's the alcohol, they group individuals in diagnostic groups. There's the alcohol population, then there's the other drugs population, and then there's the opioid population. And so when I say all, I mean, and then there's the total, which is alcohol plus other plus opioids. So when Deanne is speaking broad, I think she's referencing the all as well. So we can focus within any one of those 3 subs, because again, each one of those is a sub measure, and it's very specifically measured at each one of those levels, or in the all, in the broad. I'm going to read Christina. Did the audio go out? No, everyone's just reflecting. David, the lag time associated with initial referrals and the recognized challenges with the access led me to think that emphasis on initiation may be useful. And then Jenna, to add from the Yamhill's perspective, the first couple of years in the IT measure have been focused on building data systems. Keeping it broader will allow for more flexibility for interventions to address the RCA done in each community. So again, this is your opportunity we have obviously data. So I have exactly the performance. I have the quantitative to go with where we are and where the need is. And then, unfortunately, I had my analytics tell us exactly where we are. And unfortunately, we nationally are not in a good place. This is, again, no surprise to any of you all, I'm sure. So from a quantitative perspective, we have more than enough room for opportunity and growth in this space, which we know. So qualitatively, if there is something in your community that you want to convey to the agency to focus more in any given population by diagnostic. I'm removing the population of age from your feedback, but diagnostically, then let us know. Otherwise, I'm and the internal group will be making this choice of how to put forth the IET measure in the SUD statewide PIP arena. And then, like I said earlier, I and Sarah and the project team, the project waiver team, will be writing up the summary document, and then I will be presenting it to OHA leadership, and then hopefully getting approvals, and then making a formal announcement. Because again, this is all draft. And David has chimed in, thank you, David, that again, it'd be a disservice to other communities if we, go communities where one population is of a larger concern than others. So try to keep it there. And if there's nothing new to add, then that's okay too, because what will happen is, like I said, I will work with the analytics teams, I will work with the leadership team to formalize these conversations. And then what will ultimately happen is you all will work with your design teams. And then what will also happen, one of the conversations will be, we will be working on getting to the meat of how we get to the quality improvement. That's the fun stuff. I know you all are already enriched for that time, is when we get to whatever the topic is, the SUD managers and team are ready and waiting to provide the support and technical assistance to help partner with CCOs on what's going on out in the world, out there in the communities, out with the providers. And no, unfortunately, we cannot just, magically create a workforce. That's not possible. Obviously, we all know that, because we would love to do that too. But trying to work and partner to make things better. But we can only do that through the information of whatever you all know is happening, and then trying to figure out what we can do from this side of the shop: policy, directions, payers, etc. And that will happen once we kick this PIP off as well, because you all know I am the team of one with the PIPs, but they will be coming and support and actually be reviewing the quarterly PIP reports, the SUD team, whatever topic it is. It won't be me. It will be me plus more. So the quality improvement will happen as a team approach when we kick this one off. No one has anything to add for IET? Everybody's melting in their home offices because they don't have air conditioning?
Hey, Lisa, this is Kristen from HealthShare. I am melting in my home office because I do not have air conditioning. So you called that one. But I did want to say that I just wanted to agree, like in voice, with David and the rest of the group, just that I think we did kind of agree that, to keep it super broad. I mean, that was my sense from the previous meetings, and I'm glad. So it sounds like you all are open to that, which is cool. Oh, right, that's
Jenna,
the baseline.
Well, I'm hoping that we would be able to do concurrent. Like, I'm hoping that we could make, well, I guess Dawn, metrics guru person from HSAG. Are you on the line?
Lisa, I am on the line.
I've decided.
Can you hear me
that,
okay?
Yeah, I can. I decided that I should be giving you a new title because I want to make sure that I'm being most appropriate with gender neutral titles. So Don Grosick, which is with Health Services Advisory Group with our external quality review, he is who I call metrics guru. So everyone, if you aren't aware, I give people nicknames sometimes, and Dawn has that nickname. So Dawn, when we hadn't, I don't know if I've talked when I've talked at our last HSAG update, did I float the idea of baseline year being this year?
Yeah, no, I don't think we had got to that point yet, talking about that. And I think that was a discussion as far as like the spec changes. You know, I think you're aware of the differences between measurement year 2021 and measurement year 2022 and how the specs are different with the preceding years. So I don't think we had quite nailed that down yet.
So the answer is to the CCOs and everyone on this call, my proposal would be that this calendar, the year we're in right now would be baseline year. But I have to work that out with HSAG and whether that's even possible, so that your interventions begin January. The reason why is you all have been working on it anyways, as in it's, well, you've been working on it for years because this measure has been part of your measure set. What that means from a EQR point of view and all that kind of stuff, I have to, you know, obviously talk to Dawn and Chris and Christy, who are the HSAG team, so they can tell me what those implications are, so that y'all can know what that timing looks like from a validation point of view. So they can't, I'm not going to ask them to answer that right now because they have to go work in your work plan, your EQR validation timeline, what that looks like. And since I didn't bring it up at the July meeting, and now they're going to go work that out with your validation timelines, what that would look like, they will be able to do that and get back to me, so I can get back to you what your future validations would look like with that understanding. What we do know is August 31st would be a design phase validation, and that's this August 31st. And then they'll work out what your next validations would look like based upon the agency's request. And they couldn't, HSAG couldn't do what it would be because we hadn't made any kind of determination what measure or what topic would be. So they couldn't even, you know, propose what your validations would look like because we hadn't landed on collaboratively what a topic would be, let alone a measure, let alone what a baseline would be. So the answer is that's what we would propose. We'd have to work with the EQR, and then I would know more. Jenna, so that's that. What else was I going to say about? Oh, yes, and David Elliott's putting some stuff in there about the new specs. And I don't know if Frank Wu's on yet or not, if he was even intending to come, but there are new specs coming out from CMS. And so I have talked to our OHA analytics team, and I know our OHA analytics team is currently working on taking the new specs, HEDIS specs, to the IET and running it to the new specs. And so I do know that that's in the works already. And so that has nothing to do with whether it's a statewide PIP even, because, you know, it's an incentive measure. So that will also be part of the conversation around baseline and all that stuff. So either way, I believe the intention is the agency will have that done in a timely fashion because of the whole incentive measure part of this IET conversation, which hopefully will help in the conversation that I'll have with HSAG about whether I'll have data or not, you know, for baseline, because they'll be doing it either way for the incentive measure program. Thank you, Jenna, for your comment. So that's the proposal I would be providing our OHA leadership when I write this write-up, is that yes, I would be wanting the baseline year to be 2022. That analytics team would be running it with the 2023 specs or whatever the new specs, and that the analytics team who's running it for your incentive measure would be giving it to me as soon as they, finish it off, which I believe they're actively working on. And I'll know all that timing as soon as I think I'll know a timing, ETA of the timing in the next week or so, 2 weeks, in the month for sure. Any other questions on measurement, leadership decision points, next steps, broadening or focusing? Yes, we're using HEDIS specs. No, that's not an option that we can't. That's a given. If in fact IET is it, it's the HEDIS one, so there's no alternative. Okay, then what I know I have to do, if you think of anything qualitative to support any part of this discussion, then let me know, because I'm meeting with the internal group, I think one more time. Well, I can meet regularly, but I'm going to meet one, I think this week. Yeah, I'm meeting this week with them to finalize some more details. And then I'm meeting with leadership, I believe this week as well, later this week or next week. And then I hope to have that firmed up decision so I can work on that summary document and get out to you as well as HSAG. I think HSAG and I are meeting either this week or next week. Let me take a quick peek. I'll tell y'all, because then we're meeting next week, HSAG and I. So my goal would be hopefully by next Thursday when I meet with HSAG, that I would have that firmed up with even OHA leadership. So then ideally, if I had OHA leadership, HSAG and I confirm the validation portion of everything, then by next Thursday, I could send out some confirmation. And then we would move on from the design part of the conversation into what supports and resources do we need from an implementation and quality improvement lens at that point. That would be my best case scenario. So y'all have about a week to send me your qualitative thoughts, wishes or not, or your Hail Marys, you think you want to do something different. Anything last minute on SUD other than if you are going to send me a Hail Mary in an email, or you're going to say a woot woot, a hey yay. You can do anything else. Yeah. Okay, Laura, I think we're going to go to items from the floor. What are we going to do? What did I say we were going to do next month? What did we say? Oh, MEP. Do you want to try and do, did you want me to try and do, Real D is not ready. I tried to. Are you trying to go off mute? Oh, now she's getting mad at her computer.
Yeah. I hate that. Okay,
that was funny though.
I love Zoom. I really do. It's been a lifesaver for the last couple of years.
I know, man, that was funny though.
Okay, so we're still working on that for next month. And then
Yeah, do you want me to continue? Do you want, that one. And then I don't know if Carrie's still on, but she was working on a complaints and grievances update report. We haven't had an
that
update
would
on
be
complaints.
good.
Because I think it's going to be too early to try and do a peer learning on TQS projects. Because usually when we do a TQS, so in the past, and this is where you all can get ready to use your reactions buttons, whether it's a thumbs up or a thumbs down. But in the past, I guess there's no thumbs down. I guess you could use the, I don't know, maybe, oh, there's a whole bunch of, I guess you can use a not happy face. But we did a peer learning of the whole afternoon where you brought a TQS project and then we did breakout rooms. So we created affinity spaces based upon the TQS project that you wanted to talk about. So we basically said all CCOs pick a project on your TQS because y'all have a lot of great projects. And then you told us which project you wanted. And then we created the affinity spaces based upon themes with the projects that you put forth. And then we then publicized which projects were the themes. And then we did breakout rooms where you all talked about your projects and learned from each other. So to get that going by August 8th is pretty much unrealistic, but we can plan for September if you all think that's probably more realistic, because I would send out the call for projects right now, basically everyone, and then let you all, talk within your teams, because TQS goes across more than just the quality staff. We know it goes across your population health teams, your equity teams. There's more than just those that are on this call. We'd call for projects, we'd give you X amount of time to respond, and then we list those projects and we publicize that peer learning, which would be on September 12th. So for August, we'd do MEP, and probably, if we can, complaints and grievances if Carrie gets that lined up. And then for September 12th, we do a TQS peer learning.
Sounds good.
Does that feel good to everybody that's on the call? And you can put it in the chat, or you can, again, use a frowny face or whatever, a thumbs up. David gives a thumbs up. Okay. Then that's what we will work on, unless someone else comes up with a different idea, or you can, send Laura, your chair, something private message later. But that's what we'll work from now. We'll do MEP August and complaints and grievances most likely. And then we'll do a 2-hour TQS peer learning breakout room session in September.
Perfect.
Anyone else wants us to be, and I'll still work on a real D something or other for the fall as well. But they have some, just like everyone, have some staffing support gaps. What else? Anyone else wants to put for the good order, or everyone's just gonna go get some cold ice and find a fan?
They might have melted already.
Chips from the floor are highly recommended. Chips from the floor. Chips from the floor. David, I'm not.
Community health projects, community health incentive programs.
Does he chips? Community health improvement projects? Or does he mean like, Oh, he
when they
talking
fall
like
out of
who?
bowl.
I don't know, how does that help from the heat?
Well, I just have to say that it's past the 5-second rule, so you can't eat them.
I think we're all definitely done for the day. I think it's 114 in Arizona, from Christy from HSAG. That's hot. So me talking about well, I don't even know how hot it is here. It's 91. So Christy, 114. 91. So okay, 114. But we might have more humidity, Christy. No, actually, I do feel for all the people that don't, that are actually out on the street. So obviously we have it pretty good that we're in a home. Well, I am going to leave us with the notion of please take care of yourself. Please take care of everyone in your community. And I will, and yes, please take those stale chips from your floor and do what you will with them to your own choice and desire. I will follow up with you all after I talk with HSAG next week on the SUD PIP. You also look for the Jenny Montano email related to your actual statewide PIP, EQR, validated reports that are due for statewide PIPs, and mental health access, as well as the SUD. So Jenny Montano's email. You do have for your PCO specific PIPs, quarterly reports due July 31st. DCOs have their PIP report due on July 31st. And we will all see you in August for MEP and maybe complaints and grievances. Everyone have a good afternoon, and please stay safe for those down there in Arizona.
Yeah.
Bye, y'all.